I believe we are going to get started, but there may be slight delay as we are still waiting for the seventh member in Sacramento. Again, I'm sorry I'm not there today, um, but we're gonna get started. I know the room is still blank from my screen, so maybe it's not ready. So I'm gonna give folks at the room some time. Bryce, I believe, is running it because I see his name. Up there is the camera. Oh, I also see a couple more missing seats. So, how are we doing up there in Sacramento? And
Hey, we're just waiting on a few members to arrive.
okay,
Thank you for
okay.
your patience.
All right. So for the public, unfortunately, we cannot start yet. So we're just going to wait until all three members we're waiting is arriving, and then we will get started. So let's just put a time definitive so that we don't just wait on perpetuity, on awkward screen time. Why don't we say that we start at 9:15 today so that we have plenty of time for members to get there? Is that okay with everybody? I'm sorry. So we're gonna go on a quick break. I think everybody may had need some coffee. Go get some coffee. We'll start at 9:15 for the public. 9:15. Moderator Dan, if you could please put the timer for start time at 9:15. Appreciate it. We'll see you guys back at 9:15. Okay, hi everyone. It is 9:15 and we're gonna get started. So hopefully everyone is back, all in good shape to go. Are we good, Ann? Do we have everyone?
Hi Sung, it's Jesse. I think we have
Hi,
everyone.
Jesse. Thank you. Thank you again. I'm so sorry I'm not there in person, everyone. I really would love to, but my voice is a little worse today, so just bear with me and I'm sorry. We do get sick often time to time, unfortunately. I wish to never get sick, but it happens. So thank God for SB 544, hoping that continues on. I'm putting a plug for that bill somehow, hoping that we can continue that bill to go forward for the next year version, which I don't remember the bill version, but I know we'll talk about it at the Reg hearing. Welcome back to the April 9th through 10th, 2025 board meeting. My name is Sung Oh, president of the board. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. For protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I've advised the meeting moderator to allow 2 minutes to each individual providing comments. We'll begin with public comment for individuals attending in person, followed by public comment by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions. Moderator Ann?
Thank you. When the public comment times open, we will display instructions on the screen. The primary method is to look for the hand icon and click that to raise your hand. If you're on a computer, that hand icon should be on the bottom row of the toolbar. If you are on a mobile device, the hand icon might be behind the three-dot other options button. And if you are a call-in user, you can press *3 to raise your hand. Each speaker will have 2 minutes. As President O stated, we'll give you a 10-second warning when your time is almost up. We do ask that people only respond once per agenda item. And I believe those are the basic outlines of the rules.
Thank you, moderator. And I'd like to take a roll call to establish a quorum. Jesse Crowley.
Licensee member present.
Thank you, Jesse. Trevor Chandler.
Public member present.
Thank you, Trevor. Renee Barker.
Licensee member present.
Thank you, Jeff Hughes.
Public member present.
Thank you, Jeff. KK Ja. I don't believe KK is joining today. Jay Newell.
Public member present.
Thank you, Jay. Ricardo Sanchez.
It's Ricardo Sanchez, public member.
Thank you, Ricardo. Satinder Sandhu. I don't believe Satinder is joining. Maria Serpa.
Licensee member present.
Thank you, Maria. And Nicole Tebow.
Licensee member present, and there are no persons 18 years or older in the room with me at this time.
Thank you, Nicole. And I am here, and there are no persons age 18 years old or older in this person at this time. A quorum has been established. Truly appreciate everyone's time and commitment to the board and California consumers. I ask everyone participating today to be respectful of the work before the board. We encourage participation by members of the public throughout our meetings at appropriate times. The board respectfully requests that when comments are provided, they're done so in a professional manner, consistent with how the board conducts its business. Again, I do really want to ask the public to be respectful and to be professional when you provide your comments. That would be really appreciative. Again, and before we move to the next agenda item, I would also like to remind myself and other board member, basically just Nicole and I, to be visible on camera throughout the open portion of today's hearing. And if you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for the non-appearance when you turn off your camera. Okay, I hope the slide is all loaded up there. I am super excited for this agenda item as well as the next agenda item. We're providing some presentations and education for our members. Next agenda item 13 is presentation, discharge, medication review, and risks from Dr. Rita Shane. This morning, we'll receive a presentation from Dr. Rita Shane on discharge, medication review, and risks. Dr. Shane, thank you so much for coming, and I'm sorry I couldn't be in person. I coerced you to please come in person, and then I'm not there. So I'm sorry that I'm not there in person, but always great to see you virtually this time. But we appreciate all you do. And the floor is yours, Dr. Shane.
Okay, can you hear me? Yeah, thank you so much. Thank you for this opportunity. It was approximately 10 years ago that I asked for the opportunity to discuss medication history errors. So it's been a decade, and I now wanted to share concerns about the other end of the process when patients are admitted to hospitals. So thank you for the opportunity. So I call this the MedRec journey. You know, think about whatever is your favorite car coming to the body shop to be fixed. And essentially that's what we see in the hospitalized setting. So we're going to talk a little bit about the journey. I'm going to do a bit of a refresh on the work that we've been able to do to demonstrate the positive benefit of the law that was passed. It was SB 1254 that's now in the state board law book that requires medication histories for high-risk patients on admission, and give you a little bit of background just to kind of level set as to why it's important that we look at the other side of the admission when the patient is being discharged. Next slide, please. So what occurs is that errors that occur on admission get promulgated throughout the patient's stay, because in organizations that have electronic health records, which is almost all of them, I believe, the orders can easily be continued. So an incorrect order can be continued. And that was the impetus for why we came and discussed that as a problem, and were able to successfully pass this into law. Studies done at a number of organizations demonstrated 8 errors per high-risk patient's medication list. And we did some of that research ourselves, but it was not just at Cedars-Sinai Medical Center. And a significant proportion of those could go on to cause life-threatening or serious harm during the admission. So we're going to talk briefly about the first step, and then we'll talk about the third step, which is the focus of today's discussion. Next slide, please. So this was what was passed into law. It is linked to 4118.5 and specifically states that upon admission to the hospital, other than I think exclusion is hospitals under 100 beds, that a member of the pharmacy staff will be responsible for ensuring the accuracy of a medication profile of list for each high-risk patient. And this was actually linked to existing law, because there's a law that has this language related to pharmacy whenever a new prescription is filled. So in the community practice setting, the expectation is a review is done as a profile to avert any interactions, incorrect doses, et cetera. So we were thrilled when this came into law. The history of it was my father experienced a medication history error on admission to a hospital that was almost life-threatening, and that occurred in 1998. This bill was passed in 2018. So this bill was dedicated to my father. So thank you to the board for making this possible. Now we'll talk a little bit about the bill and the results, because we actually did a study. I said, if we can pass the bill, I will commit to doing a quality improvement study with colleagues to see, did it make a difference? What happened? Next slide. So we were able to do a multi-center quality improvement study with 11 organizations. You can see their names here, representing academic medical centers, community hospitals, and different hospitals across the state. So good representation of hospitals. Next slide. This was actually published in the American Society of Health System Pharmacists Journal in 2023. So what were our results? 6 errors per high-risk patient. Each organization used their own definition of high risk. And some of you may recall, but a lot of you were not on the board 10 years ago, that we chose to allow organizations to define high risk because a pediatric hospital is different than a cancer hospital. And so as a result of that, everyone had high risk. We just spent a lot of time planning. It was probably a good 9 months of planning the study. So we had consistent methodology, consistent data collection. And there was a process by which if an error intercepted was deemed to be such that it could cause harm, it was categorized as one that was either moderate or serious or life-threatening. And then we had physicians review at least 100 errors at each site to make sure that the validation wasn't a pharmacist either thinking something was too serious or not serious enough. Actually, pharmacists tend to underrate, just so you know. So that's the methodology. So in the course of this study, which was done over 6 weeks across the 11 hospitals, there were about 2,300 medication histories conducted. 94% of med histories had at least one error. That's pretty compelling. And 54% had a potentially serious or life-threatening error. And as I mentioned, these were at least 100 errors at each site were validated. When we looked at the number of errors captured, it was 15,850, and 25% had the potential to be serious or life-threatening. So let's take a look at a few of the errors just to give you context of what we have averted in the state of California. We are the only state that has this law. So kudos to the state board. I have worked with the state board many, many years because I've been in practice for many, many years. And the commitment to public health and safety is something I cherish and I brag about. I have had other states contact me to help them shepherd this through, and they're in various stages of doing it. Frankly, I think they're moving way too slow because I think these results are pretty compelling. Next slide, please. So this is kind of the national algorithm for categorizing severity of harm due to errors. It's put out by the USP, National Coordinating Council on Medication Error Reporting and Prevention. Try to say that really fast 3 times. Anyway, so the wheel kind of describes the risks, something that has a low capacity for harm, serious or life-threatening. So this is what we train to. And we actually, part of the training was all the sites had to rate as part of the training. So we would put up a potential error and we'd have everyone rate it. So we wanted to make sure everyone was rating consistently. And then the physicians were also trained to rate. So that way we had a degree of confidence that when we say something's life-threatening, it's not just someone subjectively thinking it, it actually could have caused serious harm. Next slide, please. So here are some of the examples. I'm not going to go through the technical pieces of it. So the first patient had cancer, also had a history of pulmonary embolism, meaning that they were at risk for a pulmonary clot, life-threatening situation. And it turned out that the patient had been taking aspirin instead of a blood thinner for 2.5 months. So had we not done the history, this patient may have never been put on a blood thinner. So this was on admission. This is the work that is the current law, and it was caught. And it was done. And these errors are not Cedars-Sinai errors. These are errors from the study. So there are any of the 11 hospitals. We just picked a few to share. Another one was an end-stage renal disease patient who'd had a transplant. Turned out that the dose that was listed on their prior to admission list was actually over 2.5-fold times what they were actually taking, because they were very sensitive to this drug and they could have, they had toxicity at a higher dose. So had we not caught that, the patient would have gotten a toxic dose during their admission. And the last patient really had no significant medical history, was put on a drug that's used for arrhythmias that can cause life-threatening side effects. Heart failure, life-threatening, even though it's used to treat irregular heart rhythms, it can actually cause life-threatening heart rhythms and heart failure. So would have likely been continued, we stopped it. So that's kind of what we've accomplished, and it's because of this State Board of Pharmacy. Next slide. So now let's focus in on the red box, which is the reason that I'm here today. So I've been working on transitions of care, as you've heard, since 1998. I am passionate about it. I'll talk to anyone who listen, including, at my grandson's first year birthday party. I corralled a physician and talked to him about med lists. And that was when we were working on SB 1254. So I asked him to write a letter of support because his practice hired a technician just to take histories because they saw all the errors that occur. In our own organization, our emergency department is now funding additional technicians to take more med histories for geriatric patients because we know that geriatric patients are at risk, just given the number of chronic diseases that unfortunately happen to our patients. So we're going to focus at discharge. I'm one of these people that once I get something in my mind that's important and to me it's a public health issue, I just need to talk about it. Okay, next slide. So what's the evidence? So 40% of patients, 2 out of 5, have discrepancies in their medications at discharge, and about half of them go on to have errors. And a third or more have significant errors. I mean, significant errors that are either moderate or serious, meaning they're harmful. They could be harmful. And the data really shows that 20% of readmissions are medication related. And I can't tell you how many times someone's admitted for something that was a medication error that had that been intercepted, the patient wouldn't have been admitted. And 70 of them are preventable. So we're talking about preventable errors. So the medication history error requirement in California, for every patient we touch, we're preventing harm. And that's 8 errors per high-risk patient. And a number of those are significant in terms of the harm that could be prevented. So I'm really proud of that. Next slide. So part of the problem, I call it the poly problem. There is a poly problem. When you look at patients who have multiple chronic diseases, they generally have multiple doctors because that is the way we care for patients. It's not like back in the day where people went to one physician who is responsible for their total care. People have multiple physicians. And then you end up with what? Polypharmacy. And the ability to bring this all together at discharge is difficult. And I'll share with you why. But I think this is largely due to the poly problem. And we know in the US, it's a problem. You've all heard it, whether you're in healthcare or just see it on the news. I mean, I actually was speaking to a number of colleagues recently, and I said, okay, based on the number of years we've all been in practice, what percentage of medications do you think patients are on that they don't need to be on? And I got a consensus number around 30%, which is a number in my head, that people are on too many meds. We once had a patient who'd been on a drug for gout for 30 years, never had gout. People just continue. Think about how busy physicians are. Think about the pressure on physicians to see patients, especially in the ambulatory care setting. And let's talk a little bit about discharge. Next slide, please. So on discharge, I'm sorry, this is too dense. I looked at it last night. I go, it's too dense, but I'm going to talk you through it. Okay. So we've got an aging population. 60% of patients have more than one or more chronic diseases. The CDC, just recently, late last year, published that 42% of patients have 2 or more chronic diseases. So chronic diseases equals meds. And meds sometimes get layered on. Sometimes the medication history is inaccurate. People in doctor's offices, you've all been to them, they take a medication history and you go, I'm not on that. That's not what I'm on. I've never been on that. Or I was on that 10 years ago. Happens to me all the time. Or they don't get the medication order sentence. They got the dose not quite right, or you're on a sustained release dosage form. So medications are sentences. We learned grammar in middle school. Medical assistants who are tasked with this because they need to do it don't always have that benefit of the knowledge. Why would they? So it creates this issue with chronic diseases, meds being added on, and who is the steward of that? Pharmacists are the steward of that. We are responsible for that. I call it, that's our guardian angel kind of charter. Make sure the meds are correct. Not only to dispense them, but make sure the list is correct, because if it's not correct, you're going to dispense the wrong drugs, and then they're going to either be taken at home or they're going to be taken in the hospital. Hospitals are at capacity or over capacity, probably over capacity. Every hospital has busy EDs, overrun with patients, can't get patients in. So the pressure to discharge patients, this whole thing called throughput, turnaround time, whatever people call it, toes in, toes out, I've heard it all. get the patient out of here. So that rush to get the patient out of here creates the perfect storm, right? So you got the discharge lists that are teed up in the electronic health record with a prior to admission list, the list the patient's on during the admission. So whatever happened during the admission, they added meds, they got the meds they were on when they came in. And then there's this list. So you know what the easiest thing to do is? Continue. And things get left, either get continued that cause toxicity. Durations are not looked at. So like an antibiotic might fall off even though a patient needs to be on them. Drugs are omitted that need to be, maybe something was held, but it needs to be continued. So we see this and it's not anyone's fault. I always say the doctor's role is to create a plan of care and based on the diagnosis and come up with a treatment regimen. The pharmacist is the one who takes that regimen and makes sense out of it in the context of the patient. Because we look at the labs, we look at the renal function, we look at other diseases, we look at drug interactions, we look at what is it going to take for this patient to not only be able to discharge and resolve the exacerbation of the disease, but how are they going to safely go home? And so all of these factors come into play, which makes discharge a really hectic time. And then the community pharmacists are now in the position of getting prescriptions without the context. So they don't have the benefit of being able to look in the electronic health record. And so if we don't get it right, at least for our high risk patients, we can't do it all. No one has those kind of resources. But at least if we could do the high risk patients, what I tell our staff is every patient you touch matters. Every patient you touch is someone's family member, and everyone has a story about medication errors due to something wrong on their medication list. So why can't we try to get to as many as we can? And why isn't this required for every patient, or at least the high-risk patients, where at least we don't want them to come back? And our community pharmacists are then the recipients of a list that's contaminated, meaning that it could be fraught with errors. And how would they know? The dose can look correct, but it's not. We only with the context of the patient do we know that. That's what we get in the hospital. We get the benefit of the electronic health record. Next slide. So this is my depiction of that. Remember that car that came in that was a wreck? So, that car came in on the tow truck, and then we basically do everything we can to fix the car, the patient, and then we drive it off the cliff. We really do. Or it drives out and then it has a problem. Something happens to the car and it needs to be fixed. Or it goes home and it comes right back again because it has another wreck, because it's a med wreck. I've always said med wreck is a WRECK, not a reconciliation. So I have fun with metaphors. So I hope you enjoyed the cars. Hope you like this car. And if you don't like red cars, I'm sorry. But I thought it kind of helped me explain what the problem is. Because we spend all this time during this hospital stay fixing the car, and then we drive it off a cliff. All right, next slide. So what's the solution? Well, there's evidence supporting that pharmacists can resolve these errors. Pharmacists' discharge medication review prevented an error in between 40 to 67% of patients. There is an average of 2 errors per patient. I can tell you this from not only studying it in an organization. I worked with an organization of a community hospital in Lancaster, Philadelphia, and I've read the literature on this. It's about 2 per patient. As a result of that, we prevent about 61% of adverse drug events, and a significant of those, they're classified as harmful. So the errors cause harm, and 25% are potentially life-threatening. So we're essentially taking a situation where patients are unwittingly, unknowingly going home on the wrong meds or an omission. And again, this is not, I talk to physicians about this all the time. In fact, our physicians are our biggest advocates of, can't you do more? I said, well, we do the best we can. Some people can't even get to it. To me, it's one of the biggest public health safety issues, not just here and probably in the country, if not the world. But it's one of those where you don't know the errors are there and they just continue. Discharge services have reduced 51% of significant errors in high-risk patients. And these errors corrected discharge, as I said, help our community peers, colleagues, pharmacists who are receiving incorrect errors and if they may not even know it. And if they do find something, because it does look wrong, they then have to take the time to clarify it. So we've already cleaned it up for them. Next slide. So we did a quality improvement study across 4 hospitals, including community hospitals. Same methodology that you heard me say for the multi-center study on medication admission errors. In that population, it was some community hospitals had sicker patients, some had, less acuity. It was more surgical patients. But even within this small cohort for 6 weeks, we had 400 patients and 409 errors. So a little over 1 error per patient. 41% of those patients had errors, and they were serious or life-threatening. And those, again, were reviewed by physicians who validate the errors, so we can say with confidence that these are serious. So whether you want to believe it's over 1 or 2, there are errors, and mostly I see up to 2. This was across hospitals, but it just validated that if you collect the data, the errors are there. Next slide. So just to give you some examples, so what are the errors? So this is a patient with multiple issues. I'm not going to get into all the detail. Every drug in that middle category under errors identified and resolved is for diabetes, blood sugar. This patient would have gone home on all of these insulin-like products or a GLP-1, and they were well controlled in the hospital just on the 1 drug. And yet they were discharged on all of these. So it was intercepted by a pharmacist. The next patient had an allergy to a sulfa and was prescribed a sulfa discharge. And it was an anaphylactic allergy. It wasn't just, a rash. And the third patient had a history of clots and a stroke and went home without any anticoagulants, blood thinners. So that's the last thing we would ever want to see. So these are just, again, examples, not from Cedars-Sinai. These are just examples of errors collected through this quality improvement study. Next slide. So my recommendation, based on this, kind of overview, background, and evidence, because we have this phenomenon of, 60% of patients have 1 or more chronic diseases in the US, of which 42 have 2 or more chronic diseases, and the phenomenon of being in a country where we're fortunate to have specialists who take care of patients and have that expertise, we have this problem. And the only profession that has the knowledge and skills to understand drug therapy management in the context of the patient is the pharmacist. So the recommendation I had was we should be ensuring the accuracy of medication lists at discharge for high-risk patients. Could we extend the current requirement that California has and add discharge? That's what I'm asking. So in summary, last slide, I promise. Discharge medication orders are associated with errors that cause harm, especially in our high-risk population. There's an average of 2 errors per patient. Many of these are serious and life-threatening. There's 4118.3.5. It says on admission, can we potentially consider adding discharge? Thank you so much for your attention.
Dr. Shane, thank you, as always, for an amazing presentation. As always, for a very amazing information. I have quite a few questions and comments for you, but I'm going to let our members go first, and I'll come back to my comments. Members, do we have any comments or questions for Dr. Shane? And again, I'm sorry, I can't see you all. I'm looking at Dr. Shane on the camera. There's no split screen here. We're not that tech savvy. So if you have any questions or comments, just please feel free to speak up.
Hi, it's Renee. Thank you so
Renee.
much for the presentation. I mean, it's very impressive, a lot of good data. So, and coming from a hospital that has very high acuity patients, pediatric patients, the med review list at all times from when they're admitted, during their stay, and at discharge is really critical, exactly due to the fact that of multiple specialists, during the hospital stay and transitions in the hospital. So I think it's very compelling for sure. Thank you so much for all your work.
Thank you.
Thank you, Renee.
Sung, this is Maria.
Oh, go ahead, Maria.
Dr. Shane, thank you for a wonderful presentation. I know that we've seen the standard of practice for admissions change, and that pharmacists are really involved with admission orders and looking at the prior to admission list. It became more complicated when everyone went to electronic medical records and introduced more challenges and more errors. And I see the same thing happening with discharge medications. I think I really do appreciate you bringing this to our attention, but I also see that sometimes we have a larger issue with all transitions of care. Many patients now are going to rehab facilities, nursing homes, board and care, all sorts of places. And when they get transferred out of the hospital, hopefully someone is looking at their medications. But if they go home or if they get transferred between nursing home to boarding care, back to the nursing home, those kinds of transitions of care introduces the same challenges. And I just wanted to thank you for the information and really be interested in seeing what electronic processes either contribute or help to deal with these issues. In my experience, it seems like without good policies and procedures, the electronic system actually makes things worse. The physician, like you said, clicks the box and says continue. And we try to deal with that for admission because we were reviewing those patients. But on discharge, they often click the box that says continue hospital meds and then continue prior to admission meds, which now they haven't been taking for sometimes a week or longer, and they want them to restart those old meds that they are no longer currently on. It's, I think, a very complicated process that those of us that work in acute care really see every day. And I appreciate that you're bringing that to our attention so that we can have a more general discussion at the board level.
Thank you.
Hi, Dr. Shane. Thank you so much for this presentation. I also love transitions of care. I don't do it personally. I'm a community pharmacist, but I'm really coming from the lens of the community pharmacist, seeing the aftermath. And sometimes it's a disaster. It really is. I mean, even as a patient, I've seen the same thing where every single time I've gone into my doctor's office, they review my med list, and then I come in the next time and all of the meds that I said I'm no longer taking are still on the list for some reason. And so there's a lot of issues on that end. But then from the community end, the example of a patient discontinuing their anticoagulant is something I see all of the time. You know, that transitions of care is so important because it's not just how do we keep this patient out of the hospital. It's realistically looking at the full picture and, you know, social determinants of health. Is this realistic for this patient? You know, warfarin, of course, isn't the standard of care, but I have patients who can only afford warfarin. And if it means that they're on an anticoagulant, sometimes we have to do that. It may be a little more inconvenient to have them go in person and get an INR, but if they're not going to take a $500 medication, we have to do what we need to for the patient. So I appreciate all of this information. I agree there needs to be definitely more emphasis on the discharge. I would love to see something happen too. And I think it's an opportunity really for a collaboration between the hospital setting and the community pharmacist. It's just so important. And I really appreciate all the work and research that you're doing here.
Thank you, Jessie. Thank you, Maria. Any other member comments or questions? Because I have a few. I'm gonna go ahead.
Nicole.
Oh, go ahead,
Oh,
Nicole.
Sorry. Thank you so much, Dr. Shane. I really appreciated the presentation. Kind of following up on what Jessie was talking about, I would love to see work next on that next step, going from a hospital to the community pharmacy. One of the biggest, I work in a clinic, in a pharmacy associated with a clinic. So we usually, the patient just got discharged, they come to see their regular doctor and then we're their pharmacy. And it's really, really hard to get a hold of someone in the hospital when we need to ask a clarifying question. So I would love to see more collaboration where we can reach a pharmacist from community can reach a pharmacist in the hospital to get some clarification, to go over things so that we can ask if they're restarting the previous meds and if something looks different and go from there. I think that would be super beneficial. So not that you don't have plenty that you're doing and on your plate, but I think it would be great to take that next step if and when it's available.
Thank you, Nicole. Um, any other members? Well, we can bring it back to you all as well, but I just have a couple questions, well, a few things. So again, thank you, but just piggybacking on Jesse and Nicole's comments, um, this is, probably just my selfish question as a person who really tries to look at the future of patient care and advancing patient care. And I think the way that hopefully we have some opportunity is a lot of these roles that discharge medication rec or admissions. I'm hoping that there can be some bridging for community pharmacies who may want to go into these positions to help hospitals. Because a lot of times these positions require PGY1 residency. They can't even apply or even be considered. I think their expertise of community pharmacy as coverage review, understanding Medicare Part D coverage, deductibles, all those knowledges could be really helpful. So I'm hoping there can be some change. That's just something, I'm mentioning selfishly for you since you have a role of chief pharmacy officer. And, hopefully there can be some considerations, for some roles that can bridge the gap of community and hospital. And that one require like a PGY1 residency because they have some knowledge of the medications at outpatient. So that's my comment one. And then question two is, as you know, most people that are in, going into hospital are very like sick, right? They're very high acuity. How often do you see like, is it pretty common, like vast majority of patients come into hospital and their medications changed when they get discharged? Dr.
So in the medical population, absolutely. In the surgical population, things may not, because
Right.
generally the surgeons are not going to do anything with the chronic meds unless the patient's having some sort of intolerance or, needs to be treated to be able to go to surgery. So the medical population is as anyone who receives prescriptions, sees prescriptions, as you know, those are the ones that are the most complicated. So I think that would be the simplest way to think about it. Most surgical patients. Now, if it's a cardiac surgery or a transplant, that's not the case. But, orthopedic surgery, we wouldn't expect a lot of changes in the chronic meds.
So
That
there's
being-
definitely an opportunity, yeah. Okay. And then one more question is about health systems, very large health systems. I work for health systems. And most of us do have the ability to, they have services providing in terms of discharge medication services that they do 30-day supply, right? Does that have that shown to help at all, reducing like any medication error reduction? Have there been any studies? Because a lot of organizations are now doing that from my understanding. So I know that small hospitals may not be able to. I'm sure size of your hospitals and many of the large health systems are all doing that. So does that help at all?
So you're talking, meds to beds is kind of the
Yes.
term going
Mhm.
around for
Right.
organizations that do that. Even with meds to beds, patients who are on chronic drugs may not want to get them at the organization because they already have their regular meds. That being said, the pressure on meds to beds, it goes back to the pressure to discharge, makes it challenging. So like we will prioritize, I've done them in our own organization, make sure you look at any antibiotics, anticoagulants, I call it the quadruple A, the A drugs, because those are the ones where the patients are getting antiplatelets. That's the other one. That's after a myocardial infarction. So they do look at it, but again, unfortunately, at that stage, it's like trying to get the patient out by 11 a.m. or by 2 p.m. puts a lot of pressure on pharmacists. And so I think that that would be ideal. And there is some work being done, but I think most people are just trying to make sure that they get the meds filled. And then when possible, do some counseling to the patient, which by the way, counseling patients at discharge is extraordinarily challenging. Think about the patient and the family trying to figure out how they're going to go home and take care of their loved one. it's not that much is absorbed at that step, even though we all know it needs to be done.
Thank you, Dr. Shin. And finally for me is, is there the legal language that you're suggesting, is that something that you're, as you know, we're going through sunset, so I don't know if there's a way, but hoping you can put forward that to people at the Capitol. And we're more than happy to try to be a help. But
Would love to, if I could get some guidance offline, I'd love to do that, if that would be the appropriate way to, I was hoping we could just kind of add it. And I'm not the expert on how to do that, but the evidence is pretty compelling, as is the experience. But yes, offline, and I would love to get some guidance as to how to do that.
And we'll try to see. Yeah, I think our questions are already set in the sunset, but I think there's some questions that are in sunset that could be, brought up to incorporate maybe these kind of topics as well. So I don't know how practically that is realistic, but at least we can try. So I appreciate your time. Members, before I let Dr. Shane go, and then any other comments for Dr. Shane?
Hi, President you made me think of a couple other things. So just wanted to touch on the counseling patients at discharge being difficult. I completely understand that. And I will say when I get the med list and all of the new medications that come when a patient has been discharged, a lot of the times they're overwhelmed. They have no idea what the medications are. Or if I read off the doctor name, they're like, I don't know who that is. And so there's a lot of confusion. Some people don't pick it up at all because they only want to pick up medications from their physicians. And then the other thing, just kind of bouncing off what Dr. O was saying about the 30-day supply of medications, I know a lot of patients who can't get an appointment with their doctor within 30 days. And so I'm not sure that supply is necessarily enough. But it is hard. I mean, when you're exhausted and when you haven't been able to sleep in 2 weeks really through the night because of how loud it is and all of the lights, it's really hard to counsel the patients. And I just want to echo what Dr. Owet had said. I think there's a really a good opportunity for community pharmacists to really be leveraged with the knowledge of, just being in the with the patient on a regular basis, understanding their insurance coverage, understanding really what an individual patient is realistically going to take in a setting. I think all of those things are just incredible. And I would love to see if we can work out a way to have this incorporated either in sunset or whatever else we need to do. Thank you.
Thank you.
Just one comment. I love where you're going. I have all sorts of ideas. I'll be 100 years old before I could get them implemented, but love to chat with you offline about some things that
Please
would
connect
be important.
offline. Don't leave, Dr. Shane. I'm sure they're all love to chat with you. Please grab Anna. I'm
So
sure.
I have one more comment also.
Oh, go ahead. Go ahead.
I sound
Maria.
like you were winding up. I just wanted to emphasize, and I'm sure Dr. Shane agrees, but to emphasize to the public and to the board members that you can't underestimate the importance of the face-to-face discussion with the pharmacist and the patient. Patients will often forget, miscommunicate, or because of embarrassment, not say what medications they're actually taking. And so looking at a list and confirming the list with time and communication is important, both at the admission and the discharge. And I'll just give you an example. At admission, we've seen time after time where someone quickly goes through the list, whether it's a nurse, a technician, or the physician, and sometimes it's a pharmacist. Are you taking this, 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 and this, and this? They'll say yes to everything because they don't want to be embarrassed that they just don't want to take their blood pressure medicine. So then they get in the hospital, they start those medications up, and all of a sudden they're having all these problems because they're taking medications they haven't taken before. Again, that also happens is on the discharge end. And one of the things is people will say, yes, I'll take my antibiotic, I'll take my anticoagulant, and then at discharge, not go pick them up, or can't afford to pick them up, or all sorts of reasons. But then going back to their physician, they'll say, yes, 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 I'm taking these things. Having a discussion with the patient, going back, old school, really is important. It is a relationship with our patients to assure that they are that we're supporting them and that they're getting what they need, that they have the access, and they have also the education to know why that's important. I think that just to piggyback on having a legislative answer, I think is really good because as Dr. Shane knows, and those of us that worked in hospitals, hospital administration is not just giving you new pharmacy FTEs. They will only do that if they're required to because of a legislative mandate. If they say it's a great idea, that's nice, but we're not giving you any money. Or we're not giving you any people, we're not hiring any different people. So the legislative mandate is really what made the prior to admission and MedRec work. And it's now the standard of practice in California hospitals. And I can see this being ideally the standard of practice for discharge too. Thank you.
Thank you, Maria. Appreciate that. Really appreciate this discussion, everyone. Again, it's always good to have these kind of talks. So I appreciate everyone's comments. Any other member comments before we go to public comment?
I have a
Dr.
quick,
Shane?
a quick
Go ahead.
thing.
Yeah,
As a
go ahead.
public member, I mean, the information's compelling for the safety of the public with the research that was done and the results that you found. But just like Maria said, it's almost got to be a legislative thing because
Absolutely.
I believe pharmacists are already really overworked. And even though you're saving lives by checking on things and ensuring they're doing their due diligence for new and old medications on discharge, do the physicians or the pharmacists have time to do that? Or is it just part of their job? You know, I just can't imagine that, like you had said, that there's enough people to be able to take that time to ensure the safety of that person being discharged. So maybe legislatively or in the rulemaking process, they can ensure that there's enough people to take that time to really handhold that patient on their way out the door to ensure that they're on a path, a good path, a healthy path forward.
Thank you, Jeff. And I think the financial motivation for hospitals are there because if they can prevent a readmission, I believe they can, this is not my areas of expertise, but please, Dr. Shane, correct me, but I believe, preventing readmissions at 7 days is extremely crucial for the reimbursements for the hospital. So I'm sure these kind of activities could definitely help. But you're right, absolutely. The legislation is necessary to get this moved forward, I'm sure. And so I think there's a lot of room for opportunities and discussions to go forward. I'm really happy that you were able to come, Dr. Shane. And so we'll continue on to our section of the public comment. So don't leave yet, Dr. Shane. We have to open up for, and hopefully you get to stay so you guys can chat during the lunch or during the break. So I hope you can connect with Anne and Jesse and all the other members about, educating more of opportunities in terms of, future. So with that, as we open up for public comment, I'd like to remind everyone present that the public comment is not intended to be a question and answer session, rather an opportunity to provide comments on the presentation. However, Dr. Shane, you are under no obligation to answer, but you can if you would like to. We're happy to let you do that if you would like. So we'll start with public comment in Sacramento. From my angle, the room is a little bit empty, so I'm not sure if anyone's there, but I will give the a minute to see if anyone walks up there to speak to you.
We do have public present here, but no one commenting.
Okay. Thank you, Jesse. I see that there's quite a few people already raised their hand on WebEx, patiently waiting. So we will go to public comment in WebEx. Moderator Ann?
Thank you. If someone would like to make a comment, you may click on the hand icon to raise your hand, and our call-in users can press *3 to raise their hands. We will attempt to go in order that the hands were raised. Each person has 2 minutes to speak. We'll give you a 10-second warning when your time is running out, and we ask you to speak only once per agenda item. Our first commenter is Larissa Betheshu. I'm going to send you a request to unmute your mic. You're unmuted. Go ahead.
Okay, so hi, my name is Larissa Betheshu. I am Speaker-elect for CPHA, Transitions of Care Pharmacist, and Chair-elect for the APHA Transitions of Care Community. So on behalf of CPHA, I wanted to speak in favor of this. I've been practicing as a TOC pharmacist for 10 years, and there's not a shift that goes by where I don't run into multiple errors at hospital discharge that could be detrimental to the patient's health. So it's well evidenced in literature that pharmacists make an impact in this area, but again, I see it every day. And what I want to emphasize is that there is a gap in that continuity of care where we're not able to, we don't have systems in place to kind of ease that transition from discharge to community or other healthcare settings. And inpatient providers do a good job of looking at the acute issues, but as patients' medications, health status, as all of these are changing, there's not really that lens of looking at how those affect their comprehensive medication list. And that's what's leading to a lot of the issues we're seeing. And those are then going to the community pharmacist who doesn't have the same access to the information and the providers to implement those changes. So having pharmacists at discharge looking at these medications is critical to improving patient outcomes. So I'm so happy to see that this is something that is being advocated for. And I want to reinforce what was said earlier too, that much of what drives pharmacist involvement in transitions of care at hospital discharge is health policies like Medicare's hospital readmission reduction program. So I think it's critically important that California is leading healthcare in having our own policies that are providing support for having pharmacists looking at medications for high-risk patients before they transition to the next of care provider. Thank you.
Thank you for the comment.
And our next commenter is Laura Zhang. And Laura, I'm going to send you a request to unmute. You're unmuted. Go ahead.
Thank you. Good morning, everyone. My name is Laura Zhang. I'm the Clinical Pharmacy Director at Sutter Health. Thank you, Dr. Shane, for the wonderful presentation. And I echo all the comments from the members speaking earlier. I have 2 points I want to quickly make. One is in Sutter Health, in our footprint, 20 plus hospitals, we have been able to implement pharmacist review discharge medications, really as what Dr. Shane illustrated, but only at about half, maybe a little bit more than half hospitals because of limited resources. And based on our data collection, I want to share with the board members that we're seeing high rate of error. It can go as high as almost every single patient go out with one prescription needed to be corrected by pharmacists. And for some hospitals with a lower rate, maybe every other patient with one prescription needed to be corrected. And again, like previous comments, this is a really significant errors impact patient care. So I wanted to illustrate it's not just in the studies, we are seeing across the board in all hospital discharge patients. So this is really the time to change the practice and then recognize the importance of a pharmacist review at the discharge medications. And then second point, I want to echo Dr. or President O's point about involving community pharmacists. Because of the legislation, we are able to secure pharmacy resource to hire pharmacists on admission, med histories, and you'll see hospital settings that start involve pharmacy technicians, the pharmacists with community pharmacy experience. Just from our Sutter Hospital alone, we're hiring staff with rich background experience. So that's actually very helpful, connect all the pharmacy members in this work. Thank you.
Thank you for the comment.
And our next request for comment is from you, Christine Chan. I'm going to send a request to unmute your microphone. You'll have 2 minutes. You're unmuted. Go ahead.
Everyone, my name is Christine Chan. I am also a clinical pharmacy director for Sutter Health. Thank you, Dr. Shane, for your advocacy in this work. One comment I just want to make is that we have in the hospital pharmacy setting, we are required by law to review and verify every single medication orders during the hospital admission. And that includes everything, including, you know, your benign topical medication or even saline flush. Those are all have to be verified and reviewed by the pharmacist. But the gap here is just really huge when the patient is at the most vulnerable state and they're going home after a sometimes life-changing event during hospitalization. The pharmacists are not required to review those medications. So I just wanted to make that point that there is a discrepancy there, and we have plenty of examples from members and other public comments that I would not go into, including my own relatives that has experienced this med rec after the patient has been discharged. So I just wanted to make that point and really appreciate Dr. Shane's advocacy in this area.
Thank you for the comment.
Thank you. And our next request for comment is from Keith Yoshizuka. Keith, I'll send you a request to unmute and you'll have 2 minutes. You're unmuted. Go ahead.
Keith Yoshizuka, California Society of Health System Pharmacists. I speak in support of Dr. Shane's proposal for medication reconciliation upon discharge. I have to stress that this can't be done in isolation and should not be restricted to just within the hospital. This information needs to be communicated to the community pharmacy, just as been indicated by Jesse, Maria, Nicole, and Son. They have to talk to each other. My God, look at the Board of Pharmacy logo. What is it? It's two people talking to each other, right? So I've been involved in hospital pharmacies for almost 50 years now. I've seen too many times where a patient gets discharged and maybe the community pharmacy didn't even know that the patient was hospitalized. Medications may have been discontinued, but the patient has that medication on automatic refill. So when it comes time, the community pharmacy refills it and has it ready for the patient. Also, even worse, if the patient was admitted as a result of an adverse drug event, that same drug may be continued, and it was stated earlier, may result in a subsequent hospital readmission. So yeah, we fully support the medication reconciliation upon discharge, and really stress, as has been recognized by members of the board, that this needs to be communicated to the community pharmacy to be fully effective. Thank you.
Thank you for the comments, Dr. Yoshizuka.
And our next request for comment comes from Sarah Stevens. Sarah, I'll send you a request to unmute and you'll have 2 minutes. You're unmuted. Go ahead.
Much. I want to speak in strong support of broadening the language to include admission and discharge for all of the reasons well articulated by Dr. Shane and also communicated by board members and the public membership that's attending this meeting. I am overwhelmed by all of the positive commentary and fully agree with everything that's been said. As a medication safety officer that's practiced both in California and outside of this state, I wanted to offer the comment that having legislation on the books to identify the responsible party and ensuring that pharmacy is at both the front end and the back end, I call it, for admission and discharge, is essential to ensuring that this happens. Even though pharmacists do this as part of their job, and we know the importance and the risk that's behind this, without having legislation on the books, you don't have the resource allocation and the board support, essentially, which makes a big difference in patient safety and patient care. Thank you.
Thank you for the comment.
Thank you. And our next request for comment is from Paige Tally. My apologies. Yes, Paige Tally. I'm going to send you a request to unmute and you'll have 2 minutes. You're unmuted. Go ahead.
Thank you, Rita, for expressing what we all know is true. I just want to piggyback on what Maria Serpa said, and that is ALFs and SNFs are critical to this issue. And long-term care has been working with HSAG, which is Health Services Advisory Group, for years with transitional care pharmacists, going back to SNFs. So I think it's important we also focus on what Dr. Serpa said as far as SNFs and ALFs go. Thank you. Bye.
Thank you for the comments, Paige.
Sure.
And let's see, our next request for comment is from Stephen Gray. Stephen, I'll send you a request to unmute and you'll have 2 minutes. And there, you're unmuted. Go ahead.
I congratulate Rita on another excellent study, an excellent idea of bringing this forward. I really appreciate what she's done for the patients, the communities, and the profession. I want to not only emphasize the validity of everything she's talking about, but I just want to point out that there's another problem that some organizations have been addressing, and that is that as much as 25% of Californians change health plans every year. They either may go in and out of the same health plan, but they change health plans. Often that means a change in their formulary, and they're put through a process where meds should be discontinued because a different med that does basically the same thing may be put on the new formulary, and that is a big change. A big problem with med reconciliation, and it is only exacerbated, of course, by a hospital admission and discharge and a lack of communication with community pharmacies. Some organizations even have hundreds of full-time pharmacists that have in their community outreach program. Actually, it's a new member outreach program where pharmacists, before the patient ever sees a program physician or other prescriber, outreach to those patients to start the medication reconciliation process. And then they take that information and it's already in the medical record for the first visit with a physician or other prescriber, such as a nurse practitioner, et cetera. So if you think of 25% of California's population, that's a huge number. Of course, much bigger than a discharge situation. I suggest asking that organization to make a presentation to the board also. Thank you.
Thank you for the, who's that okay. Let us know, Dr. Gray, who's that organization? Thank you.
You bet.
And our next request for comment is from someone logged in as DL. DL, I'm going to send you, oh, DL put their hand down. Are there any further requests? Oh, perfect. Thank you. All right. I'm going to send you a request to unmute and you'll have 2 minutes. You're unmuted. Go ahead.
My name is Donna Liang. I am the Associate Director here at Cedars-Sinai Medical Center. And thank you to the board for taking the time to discuss this really important topic, as Dr. Shane alluded to. Really appreciate all the positive feedback that I've heard this morning. And I just wanted to make a couple comments. Here we have specially trained pharmacy technicians who conduct medication histories, asking open-ended questions. And this has really enabled our patients to feel at ease, giving us their truly accurate medication information as well as their compliance. And this has enabled our pharmacists to focus on comprehensive clinical medication reviews. Our transition care pharmacists are successful and have earned the respect of our providers because they've developed an expertise that includes not only inpatient medicines, but as well as chronic disease state management. And finally, I have had multiple patients calling me, leaving me voicemails, as well as submitting standing ovations for our transition care pharmacists, expressing their gratitude and appreciation for the pharmacist's time and expertise. comments like the pharmacist has saved my life, and I have never understood my medications as well as I do now because the pharmacist took the time to really educate me on why my medications are so important. So I really appreciate the board taking the time to continue to develop um, protocols or regulations that allow pharmacists to continue to expand in the transitions of care space. Thank you.
Thank you for the comments.
And I do not see any further requests for comment at this time. Shall I close the public comment feature?
Yes, please. Thank you, moderator, and thank you, Dr. Shane. Thank you for amazing comments. Oh, I know you just want to be done there, Dr. Shane, but I was gonna give members one more time to have any comments for you or anyone from the comments we received. So just wanting to provide that opportunity one more time.
I have a question. You have like almost 16,000 errors captured, 25% have potential for serious, life-threatening injuries. How long did it take to gather that data? So over what period was it?
6 weeks, 11 hospitals.
Wow, that's just 6 weeks.
Yeah, 6 weeks. And if you think about it, so we teed
Crazy
it up.
out there.
We planned it for about 9 months, for months, because we had to engage hospitals, go through review boards, pay, all the things. But usually for data collection, in my experience, the first week is kind of bumpy. You don't even get all the data because people are still trying to make sure, even though you train them. But no, that was 6 weeks. That's
And
it.
Is this ongoing? Like, are you
Well, so-
continuing or are you?
So hospitals in the state of California are required to have this program, admission medication histories for high-risk patients. So the answer is yes. It is happening across the state of California. And as I said, we are the only state that does this, where at least we can have some level of assurance that when that patient is admitted, that history is accurate for that subset of patients. We can't do them all. Yeah, it's ongoing. It's ongoing.
Excellent
Thank
work.
you. Yeah. Thank you.
Thank you. Thank you, guys. Thank you, Dr. Shane, again, but don't go anywhere, hopefully.
No, I'll be here. No, thanks for sharing my passion. I mean, this is my, I think you could just put medication list, across whatever body part, and that's all I think. I'm pretty passionate about it, as are a lot of people. It's important. It's our patients.
Thank you. And I'm
Thank you.
hopeful. Yeah, thank you so much. And I'm hopeful that with pharmacist reimbursement status and all that stuff, that hopefully that we could actually get reimbursed and financially stable and make sense with hopefully Medicare provider status can happen. A lot of layers of many complicated situations, but I hope always, naive optimist over here, so kills me, but I try. Thank you, everybody. Okay, we're ready to move on. But before we do, I'm sorry, we do have to get a little bit of slide in something here. So there is a possibility we're going to lose a quorum in person. So we're going to take an action in order for member attending and participating from a remote location to count toward a quorum. The member must have a need related to a physical or mental disability and notify the board at the request earliest opportunity possible, including at the start of the meeting. Unfortunately, it's not at the start, but we'll do it at this point. Or if their need to participate remotely, including providing a general description of the circumstances relating to their need to participate remotely under Government Code Section 11123.2J2. Members can use the following language to make the required notification. So with that, I'm gonna let not to put you on the spot, Nicole, if you're ready for your disclosure.
No worries. I need to participate remotely due to a chronic illness and not being medically cleared to travel at this time.
Thank you, Nicole. And remember, this has to be less than 20 words, so you got an A for that. And the board then needs to take an action to approve these exceptions. So the following motion could be used, and I'm going to make the motion to keep things moving. Motion is, I make a motion based on member Nicole Tebow's description of the circumstances relating to their need to participate remotely at today's meeting. Approve member Nicole Tebow's attendance and participation from a remote location of today's meeting, and authorize that member Nicole Tebow's attendance and participation from a remote location shall count towards the establishment of a quorum as permitted by Section 11123.2J of the Government Code. Members, do we have second?
I'll second that song. This is
Thank
Jesse.
you. Thank you, Jesse. With that, we're ready for a vote. Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, KK. Is not here. Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes. Corinne, is that sufficient for us to move forward in case of we lose member number 7 in person?
Yes, it is.
Thank you. Perfect. All right, we're ready to move on. We're going to go on to the next presentation. Just for planning purposes, I'm planning to take a break at 11 o'clock. Hopefully that will be after this presentation for about 15 minutes. The next presentation, again, I really appreciate it for our next presenter, Cherie Lowe. This morning, we're going to hear from a presentation on the current hospital landscape. Today's theme, as you can see, is hospital. We really want them to feel and be heard of the concerns and the voices of hospital folks. And so I'd like to welcome Cherie Lowe, Vice President of Policy with the California Hospital Association. Again, thank you for coming in person. I'm sorry I'm not there in person, but I really appreciate you making your time there, Cherie, and look forward to your presentation.
Thank you, Chairman, President O, and my first in-person meeting. I've been monitoring you guys from my office, which is just downtown, but this is much better. You're going to start seeing me more because I like people better than screens. So we'll start there. I am not a clinician at all, so my comments are not going to be very clinically focused today. But I want to thank Executive Officer Ann and Chair President O for giving me the opportunity to present. I wanted to call it the state of the state of hospitals, but I'm not that smart. But I can give you a landscape description of where our hospitals are sort of at right now. I'm going to cover 6 topics in this presentation. I want you to understand that CHA is an organization and our sister regional associations are a resource for each of you individually on this board and for the staff for the Board of Pharmacy. I'm going to talk about the hospital landscape in California, including the regulatory environment, funding, finance affordability, and I'm going to introduce you to a new department called OHCA, the Office of Healthcare Affordability. You may think, why in the world does Cherie want to talk to us about that? But there are some great risks and benefits associated with the operation of hospitals and all of healthcare moving forward as that new office rolls out its goals and objectives. And then I'm going to talk just a little bit about hospital pharmacy practice in the hospital space versus the retail space. I've been with the association for 23 years. The last 3 years, I have had the assignment to staff the Medication Safety Advisory Group. Very happy to let you know that Rita is a member of that group, and I would classify her as one of my mentors. We have a very engaged group of about 20 pharmacists representing 20 different hospitals or health systems around the state. We are in regular communication and have regular meetings to talk about all things related to pharmacy in our hospitals. Next slide, please. So I have 3 goals for today. Raise awareness. We also want to advocate for the activation of a hospital pharmacy committee with the board. And we would like the board to bifurcate any data that they present to the public. And that bifurcation would be hospital versus the retail community space. I will tell you in the last 3 years that I have worked in this part of the public policy division at CHA, I've learned 4 things. 1, our hospitals are much more complex than I ever expected, that I've ever experienced. And the integral role that pharmacy services play in optimizing patient care can't go unnoticed. I think the second thing I've realized that hospitals don't make any decision without data, and data drives change, and accurate data is critically important to change behavior. The third thing is how difficult it is for hospitals to do one of two things, either expand the footprint of their hospital or even expand a service line. It takes on average 3 years for a hospital to add a new service to an existing footprint. If a hospital wants to actually add square footage, it's about an 8-year process. So things move very slowly in a hospital's ability to respond to the needs identified either by the hospital or by members of their community. So next slide, I'm going to start with explaining the 4 hospital associations that make up our four-legged stool. The map here on the left, I know you can't read it, and that's not intentional, but there are names and email addresses attached to every county in the state of California. And those names and email addresses are associated with a regional vice president that is assigned to have a relationship with the C-suite in every hospital in that county. So we are a large organization. We have 3 regional offices. So CHA is the statewide organization. That's why I'm here. I'm the statewide representative to the Board of Pharmacy. But if there was something that bubbled up in a local jurisdiction, I might ask one of our regional vice presidents to come up and talk to all of you. So our regional associations, so I do statewide legislature, statewide policy, all the boards and commissions. And our regional associations do local government, right? The boards of supervisors, the city council, the local departments of public health, local departments of behavioral health, the mayor's office, law enforcement. And then each of the 4 organizations of our four-legged stool have their own independently elected board of directors. So their priority issues for the year may be different than CHA's statewide priority issues for the year. And then on these next few slides, I'm going to try to lay out for you the hospital landscape. Next slide, please. So there's 439 hospitals in California. A lot of people don't understand that hospitals are not required to have an emergency department. However, we have 364 of our hospitals that have elected to have emergency departments. Another tidbit is related. We employ over half a million individuals. The average age is about $103,000 annually. And I think an important statistic is that our wages over the past 5 years have increased 35%. And I'll talk a little bit about more about that later. And then I think the most important thing on this slide is that 53% of our hospitals are operating in the red. Now that is up significantly since pre-pandemic, where we had about 30% of hospitals operating in the red. Most hospitals in the state of California are in membership with the California Hospital Association. Hospitals, well, let's just move on to the next slide, because that's going to give you a little bit of an explanation of all the different types of hospitals. So of the 450 hospitals and health systems in California, there are, well, they're listed on the slide. So we got general acute care, acute psych. I think one type of hospital people don't know a lot about are the chemical dependency recovery hospitals. We don't have very many of them in California, but we do have them. And all they do is provide chemical dependency recovery services. And then we have some specialty hospitals in the state of California. They could be a heart hospital, could be a respiratory hospital, but they specialize in one area of medicine. And then we have state hospitals. State hospitals, by and large, are the only hospitals that are not represented by the California Hospital Association. These are those very large state hospitals. Think about Napa State Hospital, Metropolitan State Hospital. They primarily These are huge hospitals, and they primarily serve individuals that have been deemed by the courts to be incompetent to stand trial. So there's not a lot of crossover with the work that the Hospital Association does with the state hospitals. Some other types of hospitals that are not well known, long-term acute hospitals and inpatient rehab hospitals. More commonly known are the children's hospitals and our rural hospitals. And just so you know, rural hospitals can either be defined by the state of California or by the federal government, and they don't always match. So it's a little confusing when you start talking about rural hospitals. And then some hospitals also receive some federal designation. You've heard of critical access hospitals. Those tend to be smaller hospitals that have a mileage distance from a major hospital system, and teaching hospitals. I think if one other thing I've learned in my 23 years at CHA, and it gets reinforced more and more every day, is if you've seen one hospital, you've seen one hospital. So they are very different and distinct characteristics. Our smallest hospital is in Surprise Valley. It's 4 beds. And 4 beds is the smallest size hospital that the federal government will certify anywhere in the United States. So we happen to have one in California. Our largest is where Rita works, Dr. Shane works, and that is Cedars. It is based in Los Angeles. It's a nonprofit hospital, and it's also a 915-bed teaching hospital. On this next slide, I'm going to try to lay out how these different types of hospitals are categorized. So the first category are public hospitals and private hospitals. So a public hospital tends to be county operated, or it's affiliated with the county. It's also UC hospitals and VA hospitals. A district hospital, also known as a public hospital, is operated by a local jurisdiction or district. And then private hospitals, which I'm sure you all are aware, can either be investor-owned or have a not-for-profit status. And then we have standalone hospitals and health systems. So obviously a standalone hospital is just that. One hospital, don't have an affiliation with the system. They are independently operated, and they are not owned by a health system. And then you have the health system. Think of the Kaisers, the Sutters, that are large, tend to be larger systems. We do have some small systems that maybe only have 2, maybe 3 hospitals in them. And I guess, let me just remind you, with the list of different hospitals that I've laid out and these different kinds of ownerships, if you've seen one hospital, you've seen one hospital. So let's move to the next slide and we'll talk about occupancy a little bit. I mentioned earlier that we don't do anything in a hospital without data to back it up, and that certainly is the truth, especially with respects to budgets and staffing. I put those 2 bullets about the pre-pandemic 65% and post-pandemic 90%. Prior to the pandemic, most hospitals budgeted for a 65% occupancy. That was a sort of an industry standard. Now we are budgeting a 90% occupancy because most hospitals are running over 90%, which causes a huge restriction on the flow of patients in and out of the hospital. And I'll talk about that in a little bit. Some of the shift in the occupancy, quite honestly, can be attributed to the behavioral health population. You see on the slide that we've seen individuals with behavioral health diagnoses grow by 26%. And chemical dependency diagnoses by 192%. Both that patient population requires a very much longer length of stay, and it's really indicative of how much has changed in the hospital environment since the pandemic. Most hospitals have shifted workflows significantly. Most have had to add new staff. Obviously, if your occupancy is going up from 65% to 90%. I think the most critical part of the hospital delivery system right now that is so close to failure, it's frightening, and that's our emergency departments. Let's talk about that a little bit more. I'll talk about that a little bit more as we move forward. This next slide sort of is laying out what is impacting our bed occupancy. And obviously, many patients put off getting treatment during the pandemic. And when they finally went to access care, they may have had challenges getting care in their community. So they further put off getting care. And now they're so sick, they're presenting in our emergency departments, and our acuity level is the highest it's probably ever been. And hopefully we can pause on acuity. We don't want to see patients getting any sicker than they already are. A lot of this, as I've already mentioned, was because people delayed care during the pandemic, but we also have a hugely aging population in California. And because of the pandemic, many primary care services that consumers could access are no longer available. They've closed. We've had FQHCs close. We've had urgent care clinics close. We've had a lot of consolidation of independent practices. And then delayed discharges. I briefly mentioned that a few minutes ago. We are having a throughput problem in our hospital because we don't have that 30% of empty beds to sort of play with to move patients around. Also, many settings where patients used to be discharged to didn't survive. Some didn't survive the downturn in the economy in 2008. Some of them came back after that, but then the pandemic just further damaged their financial situation, and they closed altogether, and they've not come back. So we know that we've got skilled nursing facilities that haven't been able to get back to full occupancy because of workforce challenges. I know some of the services that I used pre-pandemic are now no longer available to me, and I've had to turn to my health plan to say, hey, where am I going to get what I need? Because I can't get it anymore where I used to get it. So we are having a really hard time discharging patients, a really hard time. Care coordination, accountability from our health plans. Health plans have the responsibility in statute to coordinate discharge with the hospitals, and we feel that they're not doing as robust of a job as they need to do or should be doing, or that the statute requires them to do. We've got people living in our emergency departments now. We call them ED boarders. Those are people that we've already seen are ready to go on to the next level of care, or quite frankly, ready to be admitted into the hospital of the emergency department that they're sitting in. And they're sitting there sometimes for days to wait to get to an inpatient bed. We have patients sitting in our emergency department for weeks trying to get to an outpatient next transition of care location, whether it be a skilled nursing facility or an assisted living facility or a board and care facility. And then unfortunately, we have some patients that are actually living in our hospitals, and they're living in our hospitals and have been for now up to years. They even get their mail there because there is not in existence the level of care that they need. Think of someone that is medication resistant, schizophrenic, has a sleep apnea machine, is diabetic, and is pregnant. There is no place designed for that patient. So they stay in our hospitals. So we're losing bed capacity because we have an increased number of individuals living with us. Next slide, please. I'm going to transition right now to the emergency department. We're seeing 15 million patients in our emergency departments. In those 364 emergency departments, we are seeing 15 million patients annually, and it's increasing. In 2022, it's up 25%. We saw 12 million consumers in 2023. Now we're in 2025 and we're seeing 13 million. We don't see that number abating. Almost 50% of those patients that are coming to our emergency department do not have an emergency medical condition. We are seeing significant numbers of patients for primary care and urgent care treatment. Lots of patients just getting their meds refilled. They have to come to the ED to get their meds refilled. Not a great use of the most expensive resource in a hospital, the emergency department. Our average length of stay in the ED has increased by 10% since 2019. And we are seeing over 500,000 patients with behavioral health conditions in our emergency departments. Over 500,000. And that's really because the prevention and early intervention services that used to be available in our community are no longer there. So I know that no one wants to go to an ED. If you have been there, or your family or friends have been there, you're seeing this firsthand. There is not a single piece of square footage in an emergency department that has not been converted to patient care space. Every conference room, every hallway, we now have hallway beds that are permanent in our emergency departments. We have some hospitals that have permanent temporary tents that are left over from the pandemic that are being used every day, 24 hours a day, 7 days a week as overflow locations for emergency department patients. The biggest problem, honestly, with the impact in our emergency departments is that it's starting to impact the 911 ambulance response system. If the ambulances are backed up trying to get patients unloaded in our hospitals, they can't get out to the next 911 call. That impacts everybody, all of us, everybody that we care about. So we're very, very worried. I'm going to stop there and see if there's any questions on what I've already covered.
Just in regards to the people coming to fill their prescriptions at in emergency departments, and obviously they're total not the most effective use. This is because they lack access to a pharmacy, they lack documentation elsewhere. Do you know the reasons so many people are coming into the emergency department to fill those?
The array is astounding. So behavioral health meds, they just can't get in to see a practitioner to get them ordered. Inhalers, I think it's an easy way to get an inhaler, right? Come in, you can't breathe, we're going to treat you, right? They're going to hand you an inhaler. But I think there's a variety of reasons. And I think it's really dependent on the population that the hospital is serving.
Got it. Thank
But
you.
nothing's off the table
Right.
for why they ask for them.
Got it.
All right, let's go on to the next slide. I'm going to transition a little bit, and you'll understand why. I want you to get a sense of all the regulating entities that hospitals are bound by. In the state of California, there are 3 primary agencies, but they represent 12 different departments or boards. So there's a ton. Next slide gives you the federal. Primarily, this is CMS, the Centers for Medicaid and Medicare Services, followed by the DEA and the FDA. And then we've also got accreditation organizations. I didn't list on this slide all of the quality and patient safety organizations that hospitals engage with. And I think I put this slide in just because it's difficult for hospitals it's difficult for all of these oversight entities and hospitals to have cohesiveness with the rules and the regulations governing care when you have 16 different entities setting standards, rules, regulations, guidelines for everyone to follow. So we see conflicts on a regular basis. That's part of the association's role and responsibility, is to point out those conflicts and try to minimize them whenever possible. This next slide, I'm going to transition to hospital pharmacy funding and finance for a bit. And I am sorry, this slide is so small. Even I had to handwrite out my text because I can't read it with my old eyes. I want to just point out that the cost of care is absolutely outpacing revenues. We've had a 31% in growth for our hospital statewide, but only a 27% growth in revenue. So there's a disconnect there. I think most of you have heard this statistic that only 80 cents on the dollar is paid out by the state's Medi-Cal system. So Medicare isn't far behind that. They underpay as well. That means our commercial insurance market is the major player that is covering the cost of care for everyone. We also have other payers that we still have some private pay patients in California, not many, but there are still some. TRICARE. And then we have some counties that also have health plans and are offering services. But again, 53% of the hospitals in California right now, as of today, are losing money. They're operating in the red. So it's pretty much an unsustainable reimbursement structure. And we're trying to do this with 40 million people in the state of California. So the next 8 slides, I'm going to provide a very brief overview. And I just want to remind you all, I am not an expert on hospital funding, finance, or the Office of Healthcare Affordability. But I'm going to do the best to point out the risks associated with trying to fix this system. And it's a system that's been piecemeal together for decades. And then I'll introduce a little bit more about OCA. So next slide is about affordability. Labor cost, wages have gone up 34% the last 5 years. Contract labor costs have gone up 110%. We've got new state mandates I'm going to talk about, and that's with OCA and minimum wage. We've got the higher acuity and placement challenges. Our length of stay has increased significantly for inpatients by 11% post-pandemic. And then one item not on the slide that I probably will get in trouble from my leadership for forgetting to include, because it's a huge one, and that is the seismic compliance requirements. Hospitals are required to be seismically compliant by 2030. That means that not only the building has to be standing, but the hospital has to be fully functioning. The price tag for our hospitals to do that has been conservatively estimated at over $100 billion. So we are in a little bit of trouble. About a third of our hospitals right now have met the 2025 standard. Or I'm not saying this right. About a third of our hospitals as of 2025 meet that standard, which means 2/3 of our hospitals do not. And that's where the $100 billion price tag comes from. I'm going to transition to OCA now. OCA, the Office of Healthcare Affordability. This is a busy slide. I'll leave it to you to read. OCA is a new department within the Department of Healthcare Access and Information, known as HCI. A new law came onto the books in 2022 that pretty much stated that all California residents should receive health care that is accessible, affordable, equitable, has high quality, and it's universal. And in doing that, we can slow the spending, promote higher quality of care, and they're also charged with looking at market consolidation. The law was Senate Bill 184, if you have an interest in going back and reading it. Next slide, please. Again, I'm not going to read this slide much to you, but I want you to know that OCA has a responsibility to set statewide and sector-specific healthcare spending targets. It's made up of a board that is chaired by the California Health and Human Services Agency Secretary, Kim Johnson. She is their chairperson. They already have established hospitals as the first sector in the healthcare delivery system that they're going to work with. So everyone else is sort of set to the side right now, and hospitals are the sector they've selected. Hospitals make up a third of the healthcare spending in the state of California. These sectors are going to have spending targets. Our 2025 spending targets are 3.5%. By 2029, they're going to be 3%. And it's based on the hospital's previous year spending. They've also identified high-cost hospitals They've actually identified 11 high-cost hospitals in the state of California. The interesting part of those 11 that they've selected, 4 of them are operating in the red, and they're being told they have to reduce their spending. Now, they're already operating in the red. They've already reduced their spending. And if they're asked to reduce it more, that means services and staffing are going to be cut. Next slide, please. I'm going to read this first section that says, making healthcare more affordable, a priority for California hospitals. It absolutely is a shared responsibility between the state and our hospitals. But in order to make a difference in the cost of care, the entire healthcare system, the insurance companies, drug manufacturers, medical device suppliers, labor unions, government entities must work together. Nearly 2/3 or 63% of the hospital statewide healthcare spending occurs outside of a hospital. Outside of a hospital, but we're the first sector targeted. Next slide, please. There are some pretty significant headwinds that we believe the state needs to look at when determining affordability goals, and we do not believe OCA has done so. Our aging population, I'm one of those. Californians over the age of 65 is scheduled to increase by 42%. New life-saving drugs, they're great. Medical technologies, they're great. They're not cheap. And I've already mentioned state mandates like seismic and the minimum wage mandates. I think it's important for you to know that 55% of the spending in a hospital goes towards employment costs for our nurses. And our nurses are the highest paid in the nation. Next slide, please. We believe that in order to improve healthcare affordability, there needs to be many more investments in behavioral health and primary care and preventative services. And we believe that OCA, if they are able to generate any savings, those savings should be passed on to consumers in the form of reduced premiums and out-of-pocket expenses. We do not want to see these savings that are generated go back to insurance companies. The 6 largest national healthcare insurers posted a $47 billion profit in 2023. So we want savings to go back to consumers. Next slide, please. So I think it's important for you to know that OCA has no jurisdiction over pharmaceutical companies, manufacturers, wholesalers, or retail pharmacies. They do have jurisdiction over hospitals and their pharmacy operations. What is going to result from OCA's work, we've always taken a very close look at any legislation or regulations that are being proposed and looked at the fiscal impact to a hospital. Because of what's happening with OCA, that is going to take on a heightened importance as we try to help our hospital meet these spending targets. So we are going to be pretty mindful and probably more critical of any legislation or regulations that we see that have a cost impact to them. Now, if we can do a return on investment and ROI analysis and show that the cost is going to really be outweighed, that will be an important component for us to be aware of. So I think I could take questions about OCA, but I'm not an expert. I'd probably tell you to go to their website. It's pretty robust. They got a ton of stuff on it. They're meeting regularly. So if not, let's move on to the top 10 things you need to know about California hospitals.
Just before you continue, is this maybe a good opportunity for a break at all? Because I want to, because depending on how much time you have left, we don't want to rush you. I just want to make sure that this this is all information. So Do you mind we taking a break in the middle of your
I
presentation?
do not mind
or-
at all, and this is a natural place for it to happen.
Okay, that's great. So why don't we take a 15-minute break and then we'll return because I don't want to cut awkwardly. So if that works for everybody, I don't want to hold anybody's bio break. So we'll come back at 11:15 if that works, and we'll continue with your presentation if that works.
Thank
Don't
you.
have too much fun without me. All right. Okay, members, it is 11:15. Not sure how we're doing over there at the headquarters. Hoping everyone is coming back. Just for the purposes of the meeting, I'm going to announce that the member Chandler is stepped away at this point. However, we still should be good to go. She should return hopefully in about 15 minutes. But in the meantime, we'll still go ahead and get started. We're going to just take a quick roll call. Jesse?
I'm here.
Thank you, Jesse. Renee?
Present.
Thank you, Renee. Jeff?
Here.
Thank you, Jeff. Jay?
Present.
Thank you, Jay. Ricardo?
Yeah, I'm here present.
Thank you, Ricardo. And Maria?
Here.
Thank you, Maria Nicole.
Here.
Thank you. And I'm here. Quorum has been established. Cherie, thank you for your generosity of allowing us to take a break in the middle of your presentation. I really appreciate the flexibility. And so the floor is back to you, Cherie.
Thank you, President O, and I needed the bio break as well, so I appreciate the opportunity. This slide just gives you some top 10 things to know about California hospitals. We don't need to spend any time on it. I do want to transition quickly and end out my presentation with a little discussion about hospital service lines and our pharmacies. So please go to the next slide. You know, I think this board is acutely aware of the difference between hospital pharmacies and retail pharmacies. But we are, as an association, a little concerned that we're starting to see some blending of the rules, and that there is not confabulating these two very different practice settings is now starting to cause some problems. So what follows in my next couple of slides is a brief look into the differences between the two settings, the patients they serve, and some recommendations that I'd like to present to the board on how we can close the growing gap that we're starting to see. Next slide, please. I already have mentioned that hospitals are very data-driven and depend on metrics when making decisions. Those are decisions both at the macro level and at the patient bedside level. I also think hospitals are pretty far along in embracing technology for inventory management and pharmacy workflow management. And I know that our hospital electronic health records are being used to create dashboards to track a variety of data points and compliance metrics. And I think we understand and you understand that medical safety depends on setting appropriate standards, and that hospital and retail pharmacies operate in fundamentally different ways. We're really wanting the Board of Pharmacy to clearly differentiate when you're contemplating rules between and amongst those two settings. And I don't know if Rita's still here. No, darn it, because I have a quote attributed to her. She said, "Every patient, every medication, and every dose counts." And hospitals really do care about that. Next slide. Earlier, I mentioned all the different regulatory bodies that hospitals interact with. So it's really imperative from our perspective that enforcement and accountability be aligned with the scope and the practice setting, and that it recognizes the different safety thresholds and workflows in those settings, and that all oversight have tailored laws, regulations, and guidance for each setting. Next slide. The relationship that a hospital pharmacist has with the patient is very different than in a retail pharmacist relationship with the consumers. Primarily because hospital pharmacists collaborate with an entire interdisciplinary team to ensure the safe and effective use of medications. They have the electronic medical record that they use to optimize and monitor all medication therapies. Their pharmacies are vital team members in emergency response. The therapeutic decision-making is based on evidence-based guidelines. They provide clinical decision support and formulary and utilization management, and then the direct patient care. You heard from Rita earlier today on medication management pre and post pre-admission and or admission and after admission and discharge is planned. We really want to be a part of the solution and not part of the problem. So the next slide, for every guideline written by the Board of Pharmacy and for every bill introduced in the legislature and for every proposed regulation, we would really like to see the Board of Pharmacy robustly differentiate between practice settings. Obviously, applying a one-size-fits-all rule causes gaps. It increases the risks of over or under regulating one practice area. It lacks the clarity, which leads to inconsistent compliance and enforcement. And we believe it inhibits innovation. Next slide, please. With intention, we would like to see this board and the Board of Pharmacy staff actively consider structural separation at every opportunity. Please set clear, separate standards for hospitals versus retail pharmacies. Encourage compliance through setting specific guidance. Involve hospital clinical pharmacist in hospital policy development. Involve hospital clinical pharmacist in inspection protocols and report development. And realize that the current ambiguity creates legal and operational risks. In closing, I'd like to make on the next slide some proposed recommendations. Please create separate regulatory tracks, develop setting-specific training, and appoint hospital pharmacy experts to the board's committees. In conclusion, next slide, hospitals and retail pharmacies both safeguard public health. Regulations must reflect operational and risk differences, and we ask that the Board of Pharmacy lead with clear, enforceable, differentiated guidance, regulations, and laws. And please align the rules with the risk, the scope, and the setting. Next slide, please. For all of the stated reasons, CHA and its Medical Safety Advisory Group has 2 recommendations and calls to action for the Board of Pharmacy. We would like to advocate for the Board of Pharmacy to consider activation of a hospital pharmacy committee for this board, and we'd like to recommend the Board of Pharmacy bifurcate in any published reports. I just used the script as an example. When you're listing top corrections or on routine pharmacy inspections and the top violation notices for routine pharmacy inspections and in your quality assurance reporting. Next and final slide, please. Thank you for the opportunity to present before you today. I am available not only today to answer questions, I'll be able to stay through lunch, but my contact information is on this slide. I don't work traditional business hours. If you call me and I'm able, I will pick up my phone no matter what time of the day or what day of the week it is. And I look forward to continuing to get to know some of you a little bit better and working more collaboratively with the board and the leadership of the board. So thank you very much.
Thank you, Cherie. I really appreciate you coming here and providing this perspective. And we are always appreciative of your, thoughts and suggestions and input. So that is very helpful. I have a couple questions, but I'm going to open up for my board members first, and then we'll have some, discussion. So members, do we have any comments or questions? I'm going to call out Maria and Renee too, just because I know those are my experts of hospital practice. So if you have any comments or questions, suggestions, please feel free. But anyone and everyone, please go ahead and speak up.
Thank you, President. This is Maria. I wanted to thank Ms. Lowe for her presentation. I'm always excited to help the board learn more about hospital practice. You know, that for some of us, that is our daily life and seems normal, whereas to many others, including public, they don't know what's really goes on inside the hospital doors except as a patient. And so I do appreciate you opening the curtain a little bit more. The board has concerns and regulates and discusses the practice of pharmacies in a variety of settings. So it's not so simple as hospital and retail. We have long-term care, we have home infusion, we have other closed door facilities, we have nuclear pharmacies, we have lots of different forms of practice. And I hope that we take all those situations into consideration when we discuss the practice of pharmacy. And it would be really good for you to remind us if we are not considering adequately the hospital environment. I think we have hospital pharmacists that speak up also. I really liked your comment about the top concerns from inspections. The current publication is a general review, and I think there's an opportunity maybe for my committee, the enforcement, or I don't know if it comes from licensing, I think it comes from enforcement, is to maybe divide that up by license categories, because as you know, I'm very much involved with sterile compounding. So I would really be interested in knowing what are the issues in the licensed sterile compounding community, not just the HSP hospitals, but maybe that's something the board can discuss about having that information broken down by license category. Maybe we want to see what non-resident pharmacy issues are, and instead of just the big global, all pharmacies are in one big group. I really like that. The only other thing I wanted to bring up is I had not heard of, I lost it here, OHSP.
Okay.
Yeah.
Okay.
That one. I looked it up so I would look smart and actually say it correctly. And then now my page is not here. Very interested in seeing the role of that group with hospital, not only practice, but financial considerations, because I think you know, and I'm just going to say this for the public and for the non-hospital practicing pharmacists to know, is it's very difficult to have a adequate pharmacy budget inside of the hospital. The hospital itself has a whole issue with also their budgeting, because you don't know what technology is going to come. You might need $1 million machine in the OR that's unbudgeted for, or a new MRI, which is another big thing. But in the pharmacy specifically, we don't necessarily know how to adequately budget for the coming year. You can kind of project and you do your percent increases, but there are common times where we have specialty medications. And so you think, oh, you get 1, 2, maybe 5 patients on a specialty medication. That's okay. It'll be absorbed in your multi-million-dollar pharmacy budget. But the part that I wanted everyone to be aware of is that some of these specialty medications, particularly in pediatrics, can be over $50,000 per dose. It's hard to budget for that. If you get 3 patients that are needing hundreds of thousands of dollars in cost, not just in acquisition and in preparing and their hospital stay and all that, those are some of the challenges of budgeting in a hospital. And so I'm really curious to see how this, which is not a committee, this
OCA, the board.
It's
a board.
State board will navigate those complicating factors. So I appreciate that you bring that to our attention, to my attention. Thank you.
We too are worried about that.
Thank you, Maria.
This is Renee. Hi, thank you so much for your presentation and all the details. And it's always interesting to see my, my lived professional experience listed on so many slides, right? As a hospital pharmacist and specifically in pediatrics. So to say that one hospital, if you've seen one hospital, you've seen one hospital is absolutely true, of course, but also in pediatrics. So There's quite the minority of hospitals that are children's hospitals, and there's kind of some unique challenges just with that. But in some categories, it's going to be similar to other hospitals. And like Maria said, I mean, I'm the compounding pharmacist on the board, and I'm also been only in a hospital for, well, this current one, almost 30 years. Seen so many changes. But I think there's a lot of really great suggestions here. I do really like the being able to differentiate in our reports for not citation, but like with the findings and how that's broken down, because I think that would just be more helpful in general to start seeing where maybe some of the problems lie. Anyway, I think this is going to be an interesting pursuit to see how we can, address some of these hospital-specific concerns, because, there's a lot. Thank you so much.
Thank you, Renee. Any other member comments, questions?
Hi, President. Oh, yeah, I have a few questions. The first one, so this is kind of going back to earlier slides, so sorry if I didn't ask previously. On one of the slides, you mentioned contract labor expenses. What's contract labor expenses? Is that union work, or is that someone who's like just at a hospital for a specific amount of time?
It's union work.
It's the union work? Okay. I'm the union pharmacist on the board, and so I have a little perspective onto that. I know it said there was a statistic about 55% of the expenses going directly to employees, which is not surprising. Unfortunately, staffing is typically where most of the expenses go. And it tends to be a vicious cycle, because once, you have a certain budget, and especially with hospitals operating at such a deficit, you end up cutting staffing hours. And then from the labor perspective, what ends up happening is workers end up asking for more because they're taking on the work of multiple people. And so the wages tend to increase more and more. And it seems like this vicious cycle. At some point, we definitely need to look into it a little more deeply. I had a few more questions too. And I think it's actually really interesting that this presentation happened directly after Dr. Shane's presentation. I'm fully supportive of transitions of care, but then listening to all the budget issues from hospitals, I'm just not sure how hospitals are going to be able to afford more pharmacists and transitions of care. I mean, even if we're saving on readmissions, it seems like it may put hospitals at a deficit. And so I kind of wanted to get your perspective on that a little bit. Also, a question for our staff, and maybe Ann knows this. I know that we have a PIC specific training. Is it like a general training for all PIC regardless of setting, or? Yes, okay, great. And then I was wondering, because I know you had asked for maybe a hospital specific subcommittee, is that right? Are there more specific examples in which we're overlooking hospitals? I think the inspection statistics is a really great example. I think we could definitely differentiate a little bit, but it is so difficult because of the variety of settings, and it seems like the settings continue to grow more and more as pharmacy continues to evolve. And so I will say I'm not sure if a subcommittee is going to address a specific issue, or if there's like a specific thing that needs to be addressed moving forward. I fear that we could go down to a rabbit hole of subcommittees for like every part of pharmacy. And so I'm curious if there's like more specific or a specific goal to achieve in creating a committee.
Great question. How we look at it is the volume of legislation that is being proposed every year and the volume of regulations that are being produced by this board would benefit by having it's very hard. I'm going to back up here a second. It's very hard in public comment to talk with you guys in 2 minutes. I mean, that's the basic bottom line. We can't, I can bring in a gaggle of pharmacists and we can all have it one talking point. It's just not an effective use of anyone's time. So we're really looking at a way to help educate ongoing, because the practice is changing so fast in the field, for the delivery system itself and for the role that pharmacy is playing in it. You know, Dr. Shane's recommendation for more engagement is solid. It's the right thing for the patient, right? I mean, it is the right thing. I want that for me. But the Board of Pharmacy is not the only one coming at hospitals, right? It's coming at us from every angle possible. And maybe the committee is a temporary one, but we just don't feel like our voice is completely being heard. And we think that there are plenty of opportunities for us to help.
Thank you, Jesse, for bringing that up. Actually, go ahead. I think maybe instead of a committee, Cherie, and you know, maybe we could have like a listening session that we could have like an open mic that would just be a little bit more informal, because if we have a committee, then we're still, you know, bound by the certain time limitation. So maybe it could just be, you know, like we could have a couple board members and have like a listening session so that we could have more of a dialogue. I think that might be at least a possibility in trying to understand the pain points. And what I was also going to add is that hoping that more hospital colleagues can provide some comments and, you know, suggestions as to, and maybe presentations on the challenges that you all face, and anything that is an examples of the challenges. Because, you know, I can tell you, I wholeheartedly agree, and I sympathize fully with all the layers of regulation, from the feds to the states to all of us. I totally understand, with the saying that we all serve our purpose, but I understand the challenges. I really do. And I know that, you know, many cities, like if you Google or Wikipedia, some cities, and most cities' largest employers are hospitals. So I know how much you all are so important to the communities that you all serve, and I completely support and understand. So I really look forward to further discussion on this, some of the pain points, to provide the best care possible. And so I look forward to our continued discussion and work. And you know, I really appreciate your time. So I also look for, you know, opportunities for bridges, right? I always look for opportunities for bridge between the communities, hospitals, and community pharmacies. How can we all work together to help communities and patients? So I really look forward to that discussion, because in the end, we all want patients to be healthy. I don't know if this statistic is true, but, you know, I'm pretty sure it's still pretty correct. Like 50% of the cost comes from like 5% of patients or something crazy. So, you know, I think there's always an opportunity to reduce costs by engaging. I know that at the front end of the budget and the, you know, balance sheets and the income statement, all the costs of pharmacists is hard to be justified, but I know long term it's the right thing to do. We all know that, but, you know, I think we all can work together to provide that and provide that information to legislators, and all of us are acutely aware of that. So thank you, Cherie. And I'm gonna let any other members, do we have any other members, comments, thoughts, suggestions, questions? Okay, I believe Trevor's returned. Trevor, would you mind announcing your formal return?
I have formally returned.
Thank you, Trevor. Okay, members, with that, we are ready to go for public comment. If members have no other comments, but please stay after maybe hearing some public comment, we'll have more of a little bit of a discussion. So as we open up for public comment, I would like to remind everyone that the public comment is not a question and answer session, rather an opportunity to provide comments on the presentation. Ms. Lowe, you are under no obligation to answer, but you are welcome to comment and respond. We will begin with public comment from individuals participating in the Sacramento location. Do we have anyone?
Looks like we don't have any public comment here.
Okay. Do we have, and we're ready to go to WebEx, moderator Ann?
Thank you. This is the moderator. If anyone would like to make a comment on the presentation, you may look for the hand icon and click that to raise your hand. Our call-in users can press *3 to raise your hand. And each speaker will have 2 minutes with a 10-second warning, and we ask people to speak only once per agenda item. We will start with a request for comment from Paige Talley. Paige, I'll send you a request to unmute, and you'll have 2 minutes.
Thank you, moderator. Paige Talley with the California Council for the Advancement of Pharmacy. And I just want to say that I completely agree with Cherie that a 2-minute time limit is ridiculous, and it's just very, very short and doesn't allow for robust conversation. And if you could somehow get more people involved, I think it would be great. Thank you.
Thank you for the comment, Paige.
And at this point, I do not see any. Oh, we do have
one more.
raised hand from Stephen Gray. Stephen, I'll send you a request to unmute. Go ahead.
Thank you for the opportunity to comment very quickly. Just to say that I completely agree. I have been a hospital pharmacist and a pharmacist in almost every other clinical setting. And hospitals have such challenges that they really do need to have separate consideration for the policies, regulations, and standards that the Board of Pharmacy is charged with setting and regulating. So I completely agree there should be a standing committee for hospital pharmacy regulations and policies. I don't think that a listening session where a couple of board members come or it's going to be satisfactory. One of the things to point out that I think was understated, I recently was explained by a representative of a pharmaceutical company that there are drug regimens that have to be administered in the hospital. The one that impressed me the most was it requires a 5 to 11 day stay in an ICU, and the drug cost alone is $3.5 million. And the hospitals usually have to buy the drug up front before the patient is admitted. There's others in the $2 million range and so forth. So it has really changed a lot, and that is just an extreme example. But other regimens of $50,000 and so forth are not really that uncommon. So I fully support a lot of new thinking in how the Board of Pharmacy looks at hospital provided practice. That does not mean you have to go down the rabbit hole for every other type of practice, but I really do believe
10 seconds.
Pharmacy Board should support that change. Thank you.
Thank you for the comments, Dr. Gray.
And our next request for comment is from Melanie Horn. Melanie, I'm going to send you a request to unmute, and you'll have 2 minutes. You're unmuted. Go ahead.
Melanie Horn from Sutter Health, Director of Compounding. I want to also just echo what I've heard today. I thought the presentation was excellent from CHA, and the ask to create a committee that does focus prospectively on how we in the hospital health system can continue to provide excellent care to our patients. We've had historic shortages. We've had the pandemic. Many of these things have been felt very heavily in the hospital setting. And to open that dialogue and see how we in California can do better with our legislative processes and really focus the board down into the hospital setting to drive that forward, I think is time well spent. I do also appreciate the comments around understanding the regulatory and the information from our inspections related to the different areas of practice, and having that information readily available from the board would also help that dialogue to really decide where the board wants to take their efforts in legislation and be more proactive about accomplishing meaningful regulation in the areas for our patient care. So yes, I also want to echo the support for moving forward with what was presented today. Thank you for the opportunity to speak.
Thank you for the comments, Dr. Horn.
And at this point, I do not see any further requests for comment. Shall I close that public comment feature?
Thank you, Moderator Ann. I appreciate everybody's comments, bringing discussion back to members. But before, I just want to point out that I would, if it was up to me, I would love to provide public comment for unlimited amount. But unfortunately, we do have to make some tough choices because sometimes the engagement level and the ability to get things done in a public setting. Also, we have to be fair. So this is, why everybody has to be, one time 2 minutes or 3 minutes. I'm hoping that at least in the next meeting and on, we will be able to bring back at least back up to 3 minutes. But as you all know, due to some very heightened interest on certain items that we just, could not support 3 minutes. And we had to cut down a little bit because of, we had to be able to get our work done in a public meeting with, making sure everybody has an opportunity to provide public comment. So I hope that is understanding. I hope that provides some understanding of why that is the case. And we have to make sure everything is fair. Everybody has to be given opportunity to get public comment. So with that, I'm going to bring back the discussion to members. Any additional comments before we let our presenter Cherie go? And Cherie, do you have any final thoughts for us before we let you go?
No, I just want to thank you all. A good discussion, and I'm looking forward to coming back more frequently. Thank you.
Thank you. And please share with any of your hospital colleagues that you have that we would love to hear from them as well. Any interesting, creative things that they would like to present. We're always open. Thank you. Okay, members. Shifting gears to moving to agenda item 15, Legislation and Regulation Committee hearing. It is 11:47. We're going to continue on. I'm hoping that this will be hopefully done. I'm hoping to take a lunch at 12:30 p.m. for about 45 minutes. So hopefully we will go through fast. From my recollection, a lot of the items are very non-controversial, but we'll never know. We'll see. So with that, I turn the meeting over to our Chair of Legislation and Regulation Committee, Jessie Crowley, to walk us through.
Thank you, President O. On behalf of the Legislation and Regulation Committee, I'm pleased to provide a report on the committee's meeting yesterday. Thank you to my fellow committee members, Vice Chair Nicole Thibault, and members Trevor Chandler, Maria Serpa, and KK Jha. Discussion and consideration of pending legislation impacting the practice of pharmacy, the board's jurisdiction, or board operations. Members, as I shared yesterday, there are a number of measures included on the agenda today for our discussion. February 21st, 2025 was the last day for bills to be introduced. The next legislative deadlines include May 2nd as the last day for policy committees to hear and report to fiscal committees bills keyed as fiscal, and May 9th as the last day for policy committees to hear and report to the floor on non-fiscal bills. I'm highlighting these deadlines as I believe it is important to note that the legislature is very early in the legislative cycle. During our committee meeting, we noted that given that the next committee meeting is scheduled for June 11th, it is appropriate to watch some measures at this time rather than establishing a position. Such an approach will allow for us to monitor measures through at least the first policy committee hearings. The meeting agenda and materials identify pending measures impacting the practice of pharmacy, the board's jurisdiction, or board operations that were identified during the development of the agenda for this meeting. As I mentioned yesterday, as pending legislation is dynamic, measures may be amended to subsequently impact the board or its licensees, but may not appear on our agenda. For example, Assembly Bill 1366 was amended on March 28th, the same day as the release of the agenda. As such, this measure is not included on our agenda and cannot be discussed. Members, do you have any questions or comments before we proceed? Oh, Trevor?
I just wanted to make a note that at the committee meeting yesterday, I brought up and asked that SB 40 be considered at our next meeting. SB 40 relates to the capping of insulin prices. And so I look forward to discussing that at our next legislation meeting.
Thank you, Trevor. Any other comments? Thank you. Members, the first measure for our consideration is Assembly Bill 50. This measure would update provisions related to pharmacist-furnished hormonal contraception to explicitly allow pharmacists to furnish over-the-counter contraception without following the standardized procedures required for prescription-only hormonal contraception. Further, the measure would allow for the furnishing of up to a 12-month supply of OTC contraception at one time. The measure successfully passed out of Assembly Business and Professions Committee with 17 votes in support of the measure and 1 abstention. The committee is recommending that the board establish a support position on the measure. The committee also received public comment in support of the measure. With the committee's recommendation serving as a motion, do you have any questions or comments? Great. Are there any members of the public in Sacramento location that would wish to provide public comment? Okay, seeing none, moderator, we're ready for public comment from individuals participating via WebEx.
This is the moderator. If anyone would like to make a comment on the bill, you can look for the hand icon and click that to raise your hand. Our call-in users can press *3 to raise their hands. Are there any comments on this bill? I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you. And great. And if there are no additional comments, I will turn the meeting over to President O for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. The motion passes. Back to you, Chair Crowley.
Thank you. Members, Assembly Bill 447 would allow a prescriber to dispense an unused portion of a dangerous drug acquired by the hospital pharmacy to an emergency room patient under specified conditions, including that the dangerous drug is not a controlled substance, the dangerous drug has been ordered and administered to the emergency room patient, and the dispensing of the unused portion of the dangerous drug is required to continue treatment for the patient. Further, as amended, it would exempt from licensure an AUDS that is used to dispense an emergency room patient pursuant to Business and Profession Code Section 4068. During our meeting yesterday, we noted that this measure is a good example of a measure that the board should watch at this time. The measure was considered in Assembly Business and Professions Committee yesterday. As I shared yesterday, the measure passed out of its first committee with additional amendments to the measure. Those amendments are not yet in print. We had some good discussion yesterday regarding the measure during our meeting. As part of our discussion, we noted that the measure should be amended to clarify the definition of unused portion. The committee also suggested that the language should be further clarified to ensure the prescription is appropriately labeled, and further that the documentation must be available to ensure the hospital pharmacy is aware of the dispensing, etc. Public comment also suggested that the amendments should be made to ensure appropriate labeling and that the standards for dispensing are consistent with pharmacist dispensing requirements. Public comment also spoke in support of the measures specifically related to the ADDS licensure exemption. Public comment spoke in support of seeking amendments to clarify the types of medications that would qualify for dispensing for the emergency room. Public comment also noted that the emergency department should not become another dispensary and stated concern that the provisions in the measure will have impacts to the pharmacy department. The committee is not recommending a position, but rather believes the board should watch the measure and consider it for our meeting in June. Members, I welcome any comments or questions.
Thank you, Jesse. In addition to your really good summary of our discussion, I just wanted to emphasize a couple of things. One is in the definition of unused portion, we had discussion about a bulk product like an inhaler, a cream, a eye drop versus a tablet or a pill, and the concern of that being incorporated in the unused portion. I think we had a common discussion and public comment that inhalers and eye drops would be the scope that would be ideal in this kind of information, as long as it's appropriately labeled by the prescriber dispensing it. Lastly, I think I'm looking forward to more discussion, and maybe there'll be more public comment today about the AUDS being unlicensed. That in a hospital setting, oftentimes the only licensed AUDS is in the emergency room because they are dispensing, if they are dispensing medications for a person to take home. Otherwise, the AUDS in the emergency room does not need to be licensed. My concern, the difference, so there's two things. One is it's great to have everything under one umbrella so that the hospital does not have one single AUDS that's very different in regulations and monitoring than all the others in the organization. But the concern is the report requirements to the board in a licensed AUDS is to report any errors within 30 days, whereas the unlicensed ones are reported annually as part of a consolidated report. And so that's the big difference from the board's perspective. Thank you.
Thank you, Maria. And I wanted to add to that too. I think Nicole provided a really good example of post-exposure prophylaxis where, you may have to open a bottle for a patient and you're supposed to dispense it in the original bottle. So in that case, that would be another example of maybe a tablet that would be appropriate for this. And I'm sure there would be other examples that people could come up with, but definitely looking forward to see how this goes. And are there any other comments or questions from members? Perfect. Are there any members of the public in Sacramento who would like to make public comment on this measure? Seeing none, moderator, we're ready for public comment for individuals participating via WebEx.
Thank you. If anyone would like to make a comment on Assembly Bill 447, you may look for the hand icon and click that to raise your hand. Our call-in users may press *3 to raise their hands. Are there any comments on 447? I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you. Moving on, members, Assembly Bill 529 would extend the board's authority to continue to waive provisions of pharmacy law for up to 120 days following the termination of a declared emergency. The measure successfully passed out of Assembly Business and Professions Committee with 17 votes in support of the measure and 1 abstention. The committee is recommending a support position. The committee also received public comment in support of the measure. Members, do you have any comments or questions on the measure or the committee's recommendation? Hearing none, are there any members of the public in Sacramento who would like to provide public comment? Seeing none, moderator, we're ready for public comment from individuals participating via WebEx.
Thank you. We are taking public comment on Bill 529. If anyone would like to make a comment, you can click on the hand icon to raise your hand, and our call-in users can press *3 to raise their hands. Any comments on 553? Sorry, 529. I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you. If there are no additional comments, President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes for AB 529. Back to you, Chair.
Thank you, President O. Members, as amended, Assembly Bill 667 would, beginning July 1st, 2026, require boards within the DCA to permit an applicant who cannot read, speak, or write in English to use an interpreter at no cost to the applicant. The measure would specify that the interpreter cannot have a license for which the applicant is taking the examination, and it would require the board to post information regarding the provisions. It would also require the boards to update applications to ask the applicant to identify their preferred language and require boards to conduct an annual review of the language preferences of applicants. Boards would be required to report this information annually to specified committees of the legislature as specified beginning January 1st, 2029. The measure was considered in Assembly Business and Professions Committee on April 8th. The measure passed out of the Policy Committee with additional amendments to the measure. As I shared during the committee meeting, while the amendments are not yet in print, it is my understanding that as amended, this measure may no longer apply to the board. Given this, as a committee, we believe the board should watch the measure and not establish a formal position. Members, I welcome your thoughts on this measure. Go ahead, Maria.
Jesse, I just wanted to share one of the discussion items we had was we don't actually have a board policy about English proficiency. I know that there are pharmacy organizations within the state and nationally that have had robust discussions about English proficiency and the requirement to have the ability to consult and discuss with patients and patients' families. I think that there was also a discussion that was about healthcare practitioners being able to discuss patients and information with each other. So I agree with the watch position. I just wanted to state that this concept has been discussed both at the state and national level by pharmacy organizations, but not regulatory bodies.
Great, thank you, Maria. Any other comments? Okay, thank you. Are there any members of the public in Sacramento who would like to provide public comment? Seeing none, moderator, we're ready for public comment for individuals via WebEx.
Thank you. If anyone would like to make a comment on Bill 667, you may look for the hand icon and click that to raise your hand. And our call-in users can press *3 to raise their hand. Are there any comments on 667? I do not see any requests for comment. Shall I close that feature?
Yes, please.
Thank you.
Members, the next measure for our consideration is AB 669, which would ensure 28 days of inpatient, intensive outpatient, or partial hospitalization for substance use disorder treatment for patients. The measure would also prohibit insurers from requiring prior authorization for FDA-approved medications used to treat addiction that are deemed medically necessary by a doctor. The provisions would become effective January 1st, 2027. The measure will be considered during the April 22nd, 2025 Assembly Health Committee. As part of the committee's discussion, we noted that the board has historically supported measures that address barriers to access to treatment. The committee is recommending a support position on this measure, and the committee received public comment in support of this motion. With the committee's recommendation serving as a motion, do any members have any questions or comments? Great. Hearing none, are there any members of the public who would like to provide public comment in Sacramento? Seeing none, moderator, we're ready for public comment via WebEx.
Thank you. If anyone would like to make a comment on my apologies, Bill 669, you may look for the hand icon and click that to raise your hand, or our call-in users can press *3 to raise their hands. Are there any public comments? I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you.
You're welcome.
If there are no additional comments, President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes to support AB 669. Back to you, Chair Crowley.
Thank you, President O. Members, Assembly Bill 957 would prohibit a pharmacy from selling cigarettes or tobacco products. The policy goals of the measure appear consistent with the board's policy statement included in the meeting materials. The measure successfully passed out of Assembly Business and Professions Committee on April 8th. The committee is recommending a support position and also received public comment in support of the measure. With the committee's recommendation serving as a motion, do you have any questions or comments? Great. Seeing none from members, we're ready for public comment for anyone in Sacramento. And seeing none, moderator, we're ready for public comment via WebEx.
Thank you. If anyone would like to make a comment, you may click on the hand icon to raise your hand, and our call-in users can press *3 to raise their hands. We do have a request for comment from Stephen Gray. Stephen, I'm going to send you a request to unmute, and you'll have 2 minutes.
Thank
And
you
you're
for the
unmuted.
opportunity to comment. I just want to inform the board something they may not realize historically, that this issue of tobacco in pharmacies, being sold in pharmacies, was addressed first by the California Medical Foundation, the California Medical Association Foundation in the early 2000s. They asked the California Pharmacists Association to work with them on this, and the California Pharmacists Association adopted a policy that not only should it not be sold in pharmacies, but it should not be sold in any facility that has a pharmacy, such as a supermarket, a chain drugstore, or any other such facility. From that, the city and county of San Francisco adopted an ordinance to that effect. The county of Riverside attempted to adopt an ordinance. And the logic behind that was, is it right for a pharmacy to, in that facility that is being used by the facility as either a loss leader or a one-stop shop attraction, to be used as kind of a shill when the pharmacy is selling anti-cancer, anti-heart disease, anti-stroke disease, and anti-smoking products in the pharmacy, and then the patient goes to the front counter and buys cigarettes and other tobacco products. So I would encourage the board to not only support this, which I support, but to also be thinking of the idea of restricting such sales when the facility, which is where most of the tobacco products are sold, not by the pharmacy, but at the front counter at the cashier stand. Likewise, California Society of Health Systems Pharmacy later adopted the same policy. So you have full support from both California pharmacy entities for a broader measure to restrict facility selling when there's a pharmacy in the facility. Thank you.
Thank you for your comments.
And I do not see any further requests for comment on this bill. Shall I close the public comment feature?
Yes, please. And I would like to thank Dr. Gray for that comment. I think, even for myself, just reading this, I assumed it was the facility, but that's a really great point that you bring up, that there are different settings that have a pharmacy within the building. And so that's something maybe we can bring to the attention of the author's office, but thank you for bringing that up during public comment. Are we not able to? Thank you, Anne.
Yeah, just based on my discussion with the sponsors of the legislation, it includes the building, not just the license location of the pharmacy.
Great. Thank you, Anne, for the clarification. Great. And if there are no additional comments from members, President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Oh, I'm
Ricardo.
not sure if the mic was on, Ricardo.
It was on, but it was yes.
Thank
Oh,
you.
thank you, Ricardo. Maria,
Yes.
Nicole,
Yes.
and I vote yes. Thank you, everyone. Back to you, Chair Crowley.
Thank you, President O. Members, Assembly Bill 1037, as related to the board's jurisdiction, would remove the January 1st, 2026 sunset date related to pharmacists' authority to furnish hypodermic needles and syringes for human use without a prescription under specified conditions. The measure was considered by the Assembly Health Committee on April 8th and passed out of the committee. The committee is recommending a support position, and the committee also received public comment in support. With the committee's recommendation serving as a motion, do you have any comments or questions, members? Hearing none, are there any members of the public in Sacramento who would like to provide public comment? Seeing none, moderator, we're ready for public comment from individuals via WebEx.
Thank you. This is the moderator. If anyone would like to make a comment on Bill 1037, you may look for the hand icon and click that to raise your hand, or our call-in users can press *3 to raise their hand. Are there any comments on the bill? I do not see any requests for comment. Shall I close public comment on this one?
Yes, please. Thank you.
You're welcome.
Thank you. And President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes for support for AB 1037. Back to you, Chair Crowley.
Thank you. Members, Assembly Bill 1460 would prohibit a prescription drug manufacturer from engaging in discriminatory practices that would impose additional conditions or otherwise interfere with a covered entity's purchase or delivery of a drug subject to federal pricing requirements under specified conditions. The measure will be discussed during the Assembly Health Committee on April 22nd, 2025. As a committee, we are recommending a support position on this bill. As part of our discussion, we expressed concern with changes that are being sought to restrict 340B programs and noted that limiting 340B programs increases cost. The committee also received public comment in support of the motion. With the committee's recommendation serving as a motion, do you have any comments or questions, members?
Yeah, this is Nicole. I wanted to jump in on this one. I know most people don't know about the 340B program, and I'm actually an expert in this. So just to explain it to you really quickly, the 340B program is a federal program that allows certain types of entities, those that are in the safety net that serve the most underserved members of society. It allows us to purchase drugs at a cheaper price. And then we're required to take all the savings from buying those drugs at a lesser price and put them back into patient care. And the money that we get in this program comes directly out of the profits of drug manufacturers. This is not federally funded, so this comes out of their pocket. So because of that, the drug manufacturers are coming out against this really, really hard. Not surprising, they like their profits. So you're probably going to hear some disingenuous comments about the program, but please know it is literally a program that's existed for over 30 years that helps us provide extra services to the most vulnerable members of our community. So it's really, really important that we support this. Right now, the drug manufacturers are unilaterally putting restrictions on the program. This is not being authorized by the federal agency, but unfortunately that agency doesn't have the jurisdiction to stop them. So right now the states are taking action. We're one of about 25 states that has a bill to stop the drug manufacturers' actions that are happening this year. If anyone ever has questions about 340B, I'm always happy to answer.
Great. Thank you so much again, Nicole, for providing such a concise and clear summary. I think it makes it so much easier for all of us. That's information that's way over my head. Not many of us get to be experts in 340B. So thank you so much for that.
This is Renee. I just wanted to make a comment just in light of hospitals, that this also is a important program in our children's hospital system and probably other hospital systems as well.
Great.
Yeah.
Thank you, Renee. Any
Chair
other
Crowley, I just have an additional comment. I think this is a very helpful, at least a step forward. I know a lot of hospitals really rely on 340B programs to survive. So, and many clinics that are covered entities. I'm just curious if we could also convey maybe what kind of enforcement is the legislators discussing? I understand that it's a very simple statute that they're proposing, so I'm curious, how can they actually enforce this? I don't know if the end might want to kill me, but sorry, maybe we could offer ourselves as some kind of an enforcer of this too, possibly. But in some ways, most likely, probably, some other entity. But at least we could provide that, that there should be some sort of an enforcement.
Thank you, President O. I hear Anne furiously typing, so I'm sure she'll get back to us with more information at some point.
And just for context, President O, a lot of the other states that have already passed this, they're dealing with this in litigation right now. So that's part of the reason why this one was kept so simple, is because we're seeing what's happening with the litigation. In some cases, this is like 30 some odd different manufacturers that are engaging in these actions, and some of them have backed off once a rule is passed, and then some of them have gone to court over it. But we are seeing progress made in the states that have the legislation.
Great.
Thank you, Nicole.
Okay. And if we have no other comments from members, I'll open it up for public comment for people in Sacramento. Any public comment? We do have public comment in Sacramento.
Good afternoon. My name is Sean Kim from CPHA. We strongly support this legislation. We are aware of 340B program has been under attack for a while, and this is not just health system problem. We are also concerned by the community-based pharmacies that were in contract with the 340B programs too. So on behalf of CPHA, we support this legislation. Thank you.
Great. Thank you. And I believe that was the last public comment in Sacramento. Moderator, we're ready for public comment from individuals via WebEx.
Thank you. If anyone on WebEx would like to make a comment on Bill 1460, you may look for the hand icon and click that to raise your hand. And our call-in users can press *3 to raise their hands. Are there any comments on the bill? I do not see any requests for comment. Shall I close public comment for this one?
Yes, please. Thank you.
You're welcome.
So President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes on AB 1460 for support. Back to you, Chair Crowley.
Thank you, President O. Members, Assembly Bill 1503 is the board sunset measure. In its current form, the measure would update the term advanced practice pharmacist to advanced pharmacist practitioner. The committee is recommending a support position. The committee also received public comment in support of the measure. With the committee's recommendation serving as a motion, are there any comments or questions from members? Great. Seeing none, we're ready for public comment in Sacramento. We do have public comment in Sacramento.
Good afternoon again. Sean Kim from CPHA. First of all, we are really grateful for the board for its diligent and transparent work for exploring standard of care, which is omitted on the IAB 1503. So I wanted to ask for including the language into the bill for AB 1503. You guys have done great work and very devoted, meaningful time for multiple public meetings and review, analyzing the discussed approach and drawing the experience from Idaho, Washington, who already have that, and now in Iowa, where pharmacists successfully operate this framework. These public dialogues demonstrated the board's commitments in evaluating the regulatory modernization in a thoughtful, inclusive, and deliberated manner. Building onto this momentum, our organization as well as CSHP has done a lot of work on webinars, town hall, and fireside chat. But I'll let others also speak onto it too. These efforts really generated overwhelming support from the public, physicians, as well as our interprofessional settings and pharmacies. So pharmacy is ready and California is ready, and for the system that improves responsiveness to the patients. The centerpiece always is our patients and the consumers. So with that, we are strongly support standard of care to be included. And I just want to say thank you again for all the work that board has been done, and we're excited and we're hoping to move the ball together forward.
Thank you so much for your public comment. And I believe that was our last comment in Sacramento. Moderator, we're ready for public comment from individuals via WebEx.
Thank you. If anyone via WebEx would like to make a comment on Bill 1503, you may look for the hand icon and click that to raise your hand, and calling users can press *3 to raise their hands. Any comments on 1503? I do not see any requests for comment. Shall I close that feature?
Yes, thank you.
You're welcome.
Members, any additional comments or thoughts after public comment that we've received? No. Seeing none, okay. I'll turn the meeting back over to you, President O, for the vote.
Thank you, Chair Crawley. How do you vote?
Yes.
Thank you, Trevor, sorry.
Yes.
Thank you, Renee.
Yes.
Thank you, Jad.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes for AB 1503, support. Back to you, Chair Crawley.
Thank you. Members, as amended, Senate Bill 41 would establish the regulation of pharmacy benefits managers, also referred to as PBMs, within the Department of Insurance. The measure will be considered on April 23rd by the Senate Health Committee. As the meeting materials note, the board has received public comments and complaints from consumers and healthcare providers stemming from actions by PBMs. This measure is similar to Senate Bill 966 from last year that was supported by the board, but was vetoed by the governor. As part of our discussion yesterday, we noted that PBMs pose a significant threat to pharmacy practice. Additionally, it was noted that it is important that the board communicate to the legislature and governor the importance of this bill and its impact on public health. The committee is recommending a support position on this measure. The committee received public comment from a co-sponsor of SB 41 requesting that the board support this measure. And the committee also received public comment in support of the measure. With the committee's recommendation serving as a motion, are there any comments or questions from members at this time?
Hi, Chair Crawley. I just want to also, I know my silence has not been that I don't support anything. Obviously, it's just been I support, but this one I think is so important for us to also have some education and understanding. I think it is important for us to really understand what's going on. I would like to ensure that we also convey that what the pharmacy benefit managers have been doing is that they're creating what the entities called GPOs. It's not a traditional sense of what we pharmacists usually know as GPOs, but it's in the other kind of strange GPOs that are offshored. And what they're doing is instead of having a rebate negotiation, they're charging manufacturers a straight administration fees to try to bypass this kind of legislation. So I think the legislations also need to understand that there are some ways, hopefully we could provide those inputs of what's going on in the marketplace. I think this is so critical for patient care, access, consumer protection. I strongly urge that we support this wholeheartedly, and just want to make sure that we provide education on our authors, that they are already trying to have steps way ahead of this kind of legislation, even though they're fearlessly opposing it. They are already ways that they have created a loopholes in many of these rebate requirements that they're imposed by some state legislations. Another thing I would like to highlight is that in Arkansas, hopefully the governor will sign that legislation Arkansas just passed a legislation, HB 1150, that actually would require prohibition of pharmacy ownership from a pharmacy benefit manager. I'm hoping that we could also convey that that kind of a legislation would be really helpful for patient care, providing and limiting conflict of interest, because as everybody knows of dealing with this marketplace, it really is just crazy what's going on out there in terms of conflict of interest, profit motivations, and so many layers of what's going on out there is just so crazy. So I hope that we could also convey what other states are doing, and hoping that we could be a forefront of patient care and protection. And I really hope that this goes through. So just wanted to throw that out there, hoping that we could provide some education as well as along with our support position.
Thank you very much, President O. I don't think I could have said that better myself. I will just add a note that as we continue to have a discussion on standard of care, and we try to be creative, I think with the evolution of pharmacy, this is still such a critical piece of the pharmacy model that needs to be fixed. And that is a cornerstone of the reasons why a lot of pharmacies are closing, and especially independent pharmacies. So really in strong support of this as well. Are there any other comments from members? Okay, hearing none, it looks like we're ready for public comment in Sacramento. And we do have public comment for this one.
Hello again. Third time is the charm, right? On behalf of CPHA, we express our strong support as a sponsor of the bill SB 41 in the continuation of the last year's SB 966. I think the bill just became better, in my opinion. A lot of public is aware of what is going on in the healthcare system. This bill takes meaningful steps toward bringing the transparency, accountability, and the fairness for the consumers and all the providers and the payers. So this is not just one practice settings or one healthcare system. This is for everyone for the healthcare in United States. These are pro-consumer, pro-transparency, and pro-access reform that directly address long-standing issues of pharmacy reimbursement ecosystem. Just like when we talked about 340B, this is another big thing that we should also focus on. So we really, as a CPHA, we really thank the board to support and ensuring the patient access and the safety. Thank you.
Thank you. And it looks like that was our last comment in Sacramento. Moderator, we're ready for public comment via WebEx.
Thank you. This is the moderator. If anyone would like to make a comment on Senate Bill 41, you may look for the hand icon and click that to raise your hand. And our call-in users can press *3 to raise their hands. Are there any comments on SB 41? I do not see any requests for comment. Shall I close that feature?
Yes, please.
Thank you.
A little surprised, but yeah. Members, if you don't have any additional comments, I'll turn the meeting back over to President O for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
I have to abstain on this one.
Thank you, Nicole. And then I vote yes. Motion passes for support for SB 41. It's nearly 12:30, but I think we can just plow through if members are agreeable to go through. We have like 4 left, I think. 3 left.
I think we're
Is that
okay with
okay?
that. I'm seeing
Perfect.
nods over here.
Awesome. Okay, go ahead and we'll get back to you, Chair Crowley.
Thank you, President O. Members, Senate Bill 470 would make the current flexibilities provided in the Bagley-Keene Open Meetings Act permanent. The board has relied upon the current flexibilities under the temporary provisions. I agree with the recommendation to establish a support position, and I note that establishing such a position would be consistent with the board's position last year on a similar measure. The measure passed out of Senate Judiciary Committee on Tuesday, April 8th. Yesterday, as part of our discussion, we noticed that the continued availability of teleconferencing is important to ensure access to those with chronic disease or disability. Member Tebow indicated that her participation will be directly impacted should the teleconferencing option be eliminated. The committee is recommending a support position. Members, I welcome your comments if you have any. Okay. Hearing none, we're ready for public comment in Sacramento. And I don't believe we have public comment in Sacramento. Moderator, we're ready for public comment from individuals via WebEx.
Thank you. This is the moderator. If anyone would like to make a comment on Senate Bill 470, you may look for the hand icon and click that to raise your hand. And our call-in users can press *3 to raise their hands. Any comments on 470? I do not see any requests for comment. Shall I close the public comment feature?
Yes, please. Thank you.
You bet.
President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crawley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes. Back to you, Chair Crowley.
Thank you, President O. Members, Senate Bill 497 would prohibit release of medical information related to a person seeking or obtaining gender-affirming gender-affirming healthcare or gender-affirming mental health care under specified conditions. The measure passed out of Senate Judiciary Committee's hearing on Tuesday, April 8th. Yesterday, as part of our discussion, we noticed that the board has been a strong supporter of gender-affirming care in transgender community. Additionally, members discussed that there is a lot of fear amongst the LGBTQ+ community when traveling outside of California and even within California today. Members discussed that Medi-Cal requirements specify that a diagnosis code of gender dysphoria may be required in some patient profiles, which can flag someone's record. Thank you, Dr. Tebow, for bringing that to our attention, and it was suggested that this issue be raised with the author's office. The committee is recommending a support position, and the committee also received public comment in support of this measure, as well as the protections it provides. Members, do you have any questions or comments? No? Okay, any public comment in Sacramento? Seeing none, moderator, we're ready for public comment via WebEx.
Thank you. This is the moderator. If anyone would like to speak or make a comment on Bill 497, you may look for the hand icon and click that to raise your hand. And if you're a call-in user, you may press *3 to raise your hand. Any comments on the bill? I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you.
You're welcome.
Thank you. And President O.
I do see sorry, I don't know if that's accurate, moderator, but someone
Yes.
just raised their hand.
Exactly. Thank you. So call-in user 3, I'm going to send a request. You should be able to press *6 to unmute yourself, and you'll have 2 minutes. And call-in user 3, did you get a prompt to press *6? You're unmuted. Yes, go ahead.
Hi, sorry. This is my first time speaking. I just had a question in regards to asking questions about the gender that this bill is stating. Did I understand the bill right? That like the patient has the right to not discuss about the gender, and that they do not need to disclose it to the pharmacist? because this is what something I came across when I was asking in regards to one of the prescriptions. I called the doctor's office and they were not, they said they cannot confirm that identity with us because the patient was not comfortable. But the patient was described as female and they were prescribing an erectile dysfunction medication. So we were not, we could not proceed without confirming the gender, at least for what it is being prescribed. It was just a tricky situation I came across, and I wanted to discuss that.
Great. Thank you for your comment.
And I do not see any other requests for comment. Shall I close the public comment feature?
Yes, please. Thank you.
You're welcome.
Members, do you have any questions or comments after public comment? Nope. Hearing none. President O, we're ready for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes. Right back to you, Chair Crowley.
Thank you. Members, Senate Bill 548 would require the California Health and Human Services Agency on or before January 1st, 2028 to create a set of recommendations to support a 5-year implementation plan for reducing alcohol and drug-related addiction deaths by 50% by 2031 and convene a state advisory group for the purposes of advising the agency on those recommendations. The bill would require the advisory group to consist of representatives from specified entities, including the State Department of Health Care Services, amongst others. The bill would also require the agency to adopt the recommendations provided by the advisory group and to consider specified information, including the quality and performance measures, in establishing minimum standards for the effective delivery of services. The measure will be considered by the Senate Health Committee on April 30th, 2025. The committee is recommending a support position. Further, as part of our discussion, we noted that neither the board nor a pharmacist is included in the advisory group. We believe that pharmacist representation would be important for the advisory committee. Public comment spoke in support of this measure and agreed that it would be appropriate to include a pharmacist on the state advisory group. With the committee's recommendation serving as a motion, do you have any questions or comments, members? Great, seeing none, we're ready for public comment in Sacramento. No public comment in Sacramento. Moderator, we're ready for public comment via WebEx.
Thank you. If anyone would like to make a comment on the bill, you may look for the hand icon and click that to raise your hand. Our call-in users can press *3 to raise their hands. Is there any comment on this bill? I do not see any requests for comment. Shall I close that feature?
Yes, please. Thank you.
You're welcome.
Great. And President O, I'll turn it back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Motion passes on. Support for SB 548. Back to you, Chair Crowley. Last one.
Thank you, President O. Members, Senate Bill 641 would authorize the boards within the DCA to waive the application of certain provisions of board licensure requirements for licensees and applicants impacted by a declared federal, state, or local emergency, or whose home or business is located in a declared disaster area, including certain examination fee and continuing education requirements. Additionally, it would require all applicants and licensees of the board to provide the board with an email address. During the committee meeting, I highlighted that should this measure be enacted, the board would be required to pursue a regulation change related to maintaining an email address with the board. Additionally, I noted that the board would anticipate a decline in revenue. Earlier this week, the measure successfully passed out of the Senate Business, Professions, and Economic Development Committee with 10 votes in support of the measure and 1 abstention. The committee is recommending a support position. The committee did not receive any public comment on this measure. With the committee's recommendation serving as a motion, are there any comments or questions? Seeing none from members, are there any members of the public in Sacramento who would like to provide public comment? Seeing none, moderator, we're ready for public comment via WebEx.
Thank you. This is the moderator. If anyone would like to make a comment on Bill 641, you may look for the hand icon and click that to raise your hand. Our call-in users may press *3 to raise your hand. Are there any comments on Senate Bill 641? I do not see any requests for comment. Shall I close the public comment feature?
Yes, please.
Thank you.
President O, I'll turn the meeting back over to you for the vote.
Thank you, Chair Crowley. How do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeff.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. The motion passes for support for SB 641. Back to you, Chair Crowley.
Great, thank you. Members, all items included in the regulations portion of the report are for information only. As detailed in the meeting materials and associated attachments, the board has several regulations in various stages of promulgation. Similar to the approach I used during the committee meeting, I do not intend to review each item as the information is contained in public materials. The board has one regulation undergoing post-adoption review by the Office of Administrative Law, 2 regulations undergoing pre-notice review, and staff are preparing regulation documents for the ADDS self-assessment rulemaking package and revising the rulemaking package for the board's outsourcing facility proposal. During our meeting yesterday, we did not receive public comment on the regulations portion of the meeting. Members, do you have any questions or comments on the regulations? Hearing none, we're ready for public comment in Sacramento. And we have no public comment in Sacramento. Moderator, we're ready for public comment via WebEx.
Thank you. This is the moderator. If anyone would like to make a comment, you can click on the hand icon to raise your hand, and our call-in users may press *3 to raise their hands. Are there any comments? I do not see any requests for comment. Shall I close the public comment feature?
Yes, please. Thank you.
You're welcome.
Thank you. And I'll turn the meeting back over to you, President O.
Thank you, Chair Crowley. I just have one request for Ann. Under self-assessment form website we have for the board, can we put our digital signature policy statement, as I'm not sure if the general regulated public follows so closely to all our activities. So I just want them to know that digital signatures are acceptable on self-assessment forms while we provide clarity moving forward. That's all I have for little request for Ann. And with that, members, it's time for lunch. So it is 12:41. We'll return at 1:30, if that's okay, 1:30. And we'll just have a couple more things to go through. So we'll see you back at 1:30. Enjoy your lunch. Okay, hoping everybody is back. We'll take a roll call really quick. But I know sometimes we're too happy and excited to, so we'll just see how we're doing. But Jessie, are you back?
I'm here. Can you hear me?
Hi, Jess. Yes, we can.
Thank you.
Trevor?
Here, present.
Thank you, Renee.
Present.
Thank you, Jeff.
Here.
Thank you, Jay.
Present.
Thank you, Ricardo.
Here, present.
Thank you, Maria.
Here.
Thank you, Nicole.
Present.
Thank you, and I'm here. Quorum has been established. So we'll turn to agenda item 16, discussion and consideration of draft responses to sunset issues raised by the Legislative Oversight Committees. As included in the meeting material, following the board's oversight hearing on March 11th, the board has 30 days to provide official responses to the 32 issues raised in the background paper. To assist with our responses, Staff have drafted responses to each of the issues raised. So just for the process standpoint, I want to make sure everybody's on the same page. If you look at those questions, issue number 1, the background, staff recommendation. So those staff recommendation are drafted by the legislative staff. And then our response is what the board response is. So if you all remember, we've approved the new issues back in November, continuing on the final draft of all the other issues, as well as background paper for our perspective in December. And then those are submitted to the legislature in January. And then from there, the legislative staff drafted this background paper. And from there is where we are today. I hope I got that all correct, and hopefully you can correct if I said anything incorrect, just for the process wise. So that's where we are today, is we are here. Renee was so gracious in testifying at the legislature with me and Ann. So thank you, Renee. I really appreciate your support and testimony. I am very hopeful that everybody had an opportunity to review all the responses. I'm going to go through each of the issues discussed with the members, and then we're going to have a totality of the discussion for anything, and then we're going to go for public comment after that. So that's the steps. So we'll start with the issue number 1, but before that, is there any other member questions before we go on? I can't see you all really well because you all very tiny in my screen. So
I think we're
Trevor?
okay.
okay, all right, Trevor.
I was just waving so you could see me.
Oh, thank you, Trevor. And now you all are even smaller. I don't know what Ann did, moderator Ann, but oh well, it's all right. I'm gonna try to make you all bigger on my end here. Okay, so first issue raised is, they start this with a bang. Issue raised regarding board member expertise and asking if the membership of the board should be changed to include a pharmacy technician. Members, do you have any comments on the draft response? I know that our response is very neutral. I personally am actually against this idea at this point. I want to highlight at this point, but I think it's just a lot of layers of complexities and what ends up happening in some other states of what I've seen with this kind of a membership. And I'm a little discouraged at this point of the way our current law is structured. I don't know if this is the appropriate time. In the future, I'm more than happy to reconsider this issue. I'm personally against it, but I'm also looking forward to hearing members' thoughts. But even though I was against it, as you can see, I think that we left the responses very neutral. But just wanting to hear members' thoughts. And in this case, I'm gonna take your silence as your agreement with the response, whatever that we've discussed. So anybody with a dissent or a strong support, please feel free to speak.
Sung, this is Maria. Just in background, I really do appreciate the neutral response. And the board has had this discussion many years ago. It was very complicated. Unfortunately, nothing that we do seems to have like a really easy solution. The pharmacy organizations were involved and there was lots of discussion. And one of the things to note was the disagreement on the number of pharmacy members versus lay members of the board and the makeup of the entire board when an addition is being proposed. And so it's very complicated. So I do appreciate the neutral nature, and maybe we can open that discussion another time in the future.
Thank you, Maria. Any other members? Go ahead,
Yeah,
Trevor.
Yeah, I agree with being neutral on this. I don't innately oppose the addition of a tech role, just very democratically. I mean, techs are a member of our regulated public, and as a board that regulates them, I think every community should have that sort of voice. And so I lean on the more like in favor of making sure that every member of the regulated public is included in our decision-making process. That being said, I just think it's a much bigger conversation than putting into sunset. So I support having the conversation. I just don't think this is the right time to do it.
Thank you, Trevor. Thank you for a thoughtful response there. Any other members?
Hi, Sung. This is Jessie. I'm actually in strong support of having a pharmacy technician represented on the board. I think this is an opportunity for us to really get more engagement from some of our pharmacy technicians. I've said multiple times on this board, but I do also think that should be coupled with providing more autonomy, especially as their role continues to expand. But we're seeing that more and more. And so I think creating a position for technicians would really be having the board evolve with the evolution of technician roles that we're seeing. I do agree with Trevor that this may not be the right time, but I'm hoping that we can continue having this discussion, at least on the board level, moving forward.
And I also want to add that I think that what I'm hoping to do is, I think eventually our technicians are going to have to pick up more, a responsibility. And so I'm hoping to look at in the totality of their roles to really assist pharmacists in providing care for patients. So that's what I'm hoping to do in the long run as we move forward. Members, any other thoughts?
Hey, Sung, it's Nicole.
Go ahead.
I like the idea of having them. My question becomes, what role do they fill on the board? Like, do we add another person? Because if they take one of the licensed roles, techs tend not to be as knowledgeable about the law. They're not charged with knowing it. That's the charge of the pharmacist.
That's
So
exactly.
I'd be a little hesitant to take a licensed role for a tech because they don't do the CPJE and they don't go through the law. So I would love to see them there, but I would be concerned in where we put them and how we do that.
Good point, Nicole. Okay, any other thoughts, members? Unless there's any suggestions to change the response, though, at this point, I think that we're just going to maintain our kind of a response. So if there are any recommended changes to the response is what we're really working on today. So took a very neutral tone. I would like to maintain that tone. I think we're not having a consensus. And I know this issue is very, very controversial. I know at least from what I heard from the last time the board discussed. So I don't want us to, I want to stay kind of calm here unless the legislators really want to do this. And then at that time, we could probably have a better, response. Any other thoughts, members?
Hi, Sung. This is Jessie. I will say, I think that the language, the neutrality is really good. I'm not sure. Let's see. The board should inform the committees of any professional perspectives. I think maybe just there could be more clarity, just specifying that, we plan to continue the discussion moving forward, just so that they know that we're, taking their recommendation into consideration.
Thank you, Jessie. And I'm sure you're fearlessly typing all this because just in case, because the motion is going to be as discussed by the board, I'm sure, and also delegating the authority to myself as well as Anne in understanding the policy direction of the board. So I think that that's a very neutral, agreeable thing to add. Any other member thoughts? I don't see anyone speaking up, so we're going to move to the next issue. We have 32 to go through, everyone. So we're gonna get through it as much as we can, as fast as we can. So hopefully it won't take too long, but most of them are very non-controversial that we've discussed ad nauseum for many years until this point. So issue number 2 is asking if the board has sufficient legal counsel. I'm going to just say if any member have any comments or questions on this.
I think our counsel is more than sufficient. They're great.
Yes, We were very lucky to have our council.
Yeah, I was
Corinne
gonna
and
say the same. I just want to keep Corinne. I really I really like the attention to detail. Really,
yes, yes.
really
Thank you, Corinne.
warms my pharmacist heart.
Yes, and Shelley also very hardworking.
Shelley too.
And then also I know that our prior councils for the board has been extremely helpful. Laura Friedman and Eileen Smiley and Noreen Marks and probably many that I'm not naming because I wasn't here, but I really appreciated all their wonderful work. Okay, number 3 is regarding the board's fund condition and asking if the board's fees are sufficient to cover future revenue. Very simple response.
Can we put in a passive aggressive note about wanting our $4 million back from the general fund? And no, we can't do that. Then we'd have a great, then we'd have a great reserve fund. That was a joke.
Okay. Thank you, Trevor. Okay, so I think that everybody's agreeing to that. Moving on to licensing issues. This is where not that controversial, but issue 4 is related to retitling. As our spot bill says, I think this is such a non-controversial issue that they use this as a spot bill for our AB 1503, our sunset bill. So I'm sure this is very non-controversial, but retitling advanced practice pharmacist to advanced pharmacist practitioner. And so members, again, silence as your agreement. So no need to like speak up if you're okay, unless you feel very strongly something is not right or that you feel that you would like to amend something. And I know our AV person over there is just focusing on Trevor right now, but I don't see anyone. So I don't see anybody's speaking up. So we're moving on. If there is, please just speak up. I know I can't see you all. I can't see your body language. So please just speak up. Next, here we go. Getting interesting here. Issue number 5 is related to the board's proposal to regulate IV hydration clinics that operate without specified oversight while compounding occurs. I just want to highlight that this is for a site that does not have any real oversight. So I think that this might possibly generate a lot of misinformation of what we're trying to do. So, and I know this is a very thorough response. I appreciate our staff drafting this response very thoroughly. Members?
This is Renee. Yeah, I think I would put my strong support here. But I think, and also, like you said, highlighting the intended narrow scope, and specifically that last sentence, the statutory proposal is intended to be narrow in nature and address regulatory gaps that have been identified, and not some broad sweeping, anybody who does IV hydration, right? So just to make that really clear, because I do think that there could be some misunderstanding about this. So, and clearly FDA has already made some alerts of findings, and there have been deaths and people have been injured from these IV hydration, clinics or pop-ups. So I think it's definitely a health, consumer safety risk. So, but again, narrow in scope.
Thank you. I wish there's a way to like highlight and bold and underline, but I think we have to maintain the formatting of the legislative report. So, but thank you for the comment, Renee. Any other member comment?
Yeah, Sung, this is Maria. I
Go ahead,
think
Maria.
that in reviewing the information, to be careful to highlight, I know you said no, you can't bold, you can't do things, but I think that there's misinformation or people that come with a preconceived information may not read the detail. and that we are looking for, facilities that do not have engagement of healthcare practitioners, and to really highlight that in some way. I think that a rabbit hole that might be addressed in here is when it says when the healthcare practitioner is not on site. I think at all times is a potential rabbit hole that means that sometime, if they're there sometimes, that we're interested in those facilities too. I think it should be better to be black and white, is to talk about, no healthcare practitioners involved in the practice or something like that, rather than saying, it's not a physician infusion center or infusion clinic where the physician is there 3 days a week, but they provide infusions 5 days a week. I don't think we're interested in that setting just because the physician's not there
Right.
2 days a week. And I think that could be misunderstood. And with that in mind, I would suggest a change in the wording where it says a case example is provided, that we remove the word medical clinic and just say clinic. I think medical, you think of doctor's office.
Gotcha. Perfect. Great suggestion, Maria. I think that's absolutely agreeable. I'm sure everybody's agreeable. Silence as an agreement, hopefully. Any other thoughts, members? Not seeing anyone. So
Sorry,
go
this
ahead.
is Renee. Yeah,
Go ahead, Renee.
actually, I appreciate Maria's comment because I would agree that that did stand out to me, but I was thinking more in terms of like later discussion. But if we could, about the number of, like, if there's going to be a day where there's not oversight, like we don't, I think with what could be implemented, obviously they don't have to be there seem to be on there on that day. But I just wanted to see if I was trying to review the FDA presentation, if we remove, not to change what is in the, sorry, I'm not out of what FDA's alert says, right? So if FDA's alert says it's a medical clinic, that would be my only request, that we look to see that are we just referring to it as a medical clinic, or in the FDA report of it that they refer to it as a medical clinic, right? So anyway, I just was starting to go through that. Obviously they're talking about there's a landscape of IV hydration facilities. So I guess that if we did, it would just be if we only termed it as medical, then we can change it. But if it's defined by FDA in their report that it was medical, does that make sense? Like,
Yeah.
The report is the report. So our intent is not for, a licensed physician, right? I think they could use the term broadly of medical, right? Because somebody's getting, it's a medical treatment for them, but may not be a licensed, somebody who can provide compounded items.
So this is very
Okay.
complicated. I think that
Uh-huh.
the challenge is, I think between the president and Anne, you understand our intent is to not target this to make it look like it's a
Doctor's office.
influence on physicians or other healthcare practitioners. And so
Right.
I'm not
Yes.
so detailed about the words. It's mostly about the intent that
Mhm.
that there's no
To clarify.
misunderstanding or confusion with the general public.
Okay.
And because even in this report, so they talk about that I'm looking at their presentation, but if they're referring to the October 2021 compounding risk alert, it is to hydration clinics, medical spas, and mobile IV infusion services. So that's the terminology, that's the quote they're using. So if we're paraphrasing from them, we can take it out. If we're trying to relate the FDA alert, then I feel like we can't take it out or put some disclaimer.
Got it. Okay. I think I understand what we're trying to do. So that's, I think, an easy way forward. So, okay. Any other member thoughts? I'm not seeing anyone, so we're ready to move on to the next is the issue 6, number 6, pharmacy delivery services. Again, we kept it very general because I know this issue could be a lightning rod if we start trying to regulate Uber drivers who's driving prescriptions, or USPS who's mailing prescriptions for pharmacy. So I think that this is not a bad first step. So hoping that that is an agreeable angle to go for now, just focusing more on opportunity for education. Again, we're focusing on the response, not the policy directions, just because we've already talked about a lot of policy directions on these. So we're just working on the responses, just making sure everybody's on the same page.
Sung, this is Maria. When I first read this, I understood the intent, and I just wanted to make sure that it's clear to, and maybe just adding another sentence, or maybe it's clear enough the way it is, that this is not involving delivery services from wholesalers to pharmacies. That's a common delivery method.
Yes.
Also from manufacturers to pharmacies, we often get direct deliveries from manufacturers to the pharmacy too.
Right. Thank you, Maria. Great comment. Any other member comments on this? I think that that's a great suggestion to clarify that this is discussing a delivery of a prescription medications from a pharmacy to the consumer. So in whatever, whoever that pharmacy is. Thank you. Go ahead, Jesse.
It's Jesse. The only comment I have on this piece is the sentence where it says evidence of completion of a potential online training program could be provided to a pharmacy prior to the release of a prescription for delivery. Like realistically, I don't know if that would really work, and like, is that just putting the onus on the pharmacy at that point and the pharmacy staff? So not necessarily to like take away an example, because I think some sort of sample, I like the idea of an online training program, but maybe working out the details on the evidence of completion. I don't really know a solution necessarily, but that's the one thing that just comes to mind.
Maybe we could neutralize that statement a little bit or strike that out, because I don't think that a pharmacy, maybe just like legally speaking, I think that if there's any language, I don't know how anybody would be held accountable. So I think the only way is just to provide strong recommendation for education, not as a legal requirement. So maybe we strike that out, or that we leave it more neutral. Like this is not a suggested language in legal requirement, but more of a suggested offer for pharmacies who's contracting with a courier services to consider that there is an education program that the Board of Pharmacy is providing, something like that. So more neutral.
Yep, that sounds good.
Okay. Members, are we good with that? Okay. Okay, issue number 7 is the board's ownership prohibition proposal. This is something that we've been trying to get it through the legislature for the last, I believe, 4 or 5 years. It's very dated issue. We've been just trying to make sure. I think it's hopefully we'll finally make it in, just to clarify so that there's some clarities provided. I think it's non-controversial, but any other thoughts from members? Not hearing anything, so we'll move on. Issue number 8 is the board's retired pharmacist license proposal. Again, I'd like to call out our a person, Vicky, I believe, I don't remember her last name, but I know that's Maria's very close colleague, for bringing this to us, our attention, because I do agree as a policy that there was some opportunities for retired pharmacists or who are nearing their retirement to be able to kind of have some, because, do you want to give it up the whole thing? Because if you do come back from retired, you have to retake the exam, and nobody wants to do that, I understand. So it's just a lot of, so now that this proposal gives them a 3-year, 3 years, right, Ed? Yes, 3-year opportunity. If you keep up with the CE, they can just come back and turn the license back on as long as you do their CEs. So I think this is a great idea. Any other comments for this, members? Don't see anyone, so we will move on to issue number 9 is the board statutory proposal related to restoring some discretion in making licensing decisions. This one is actually requested by our staff, and we included this as a continuing discussion from our old issue from the past sunset. Has a long history, and would love to get members' thoughts on this. And totally okay to just be supportive of the response as drafted. So silence as an agreement. Okay. We're moving on to issue number 10, the board's statutory proposal related to pharmacy technician trainees. Again, we're moving on to now education and examination issues. So issue number 10 is the board's statutory proposal related to pharmacy technician trainees. I know this is a recent discussion we've had just to try to provide some kind of a easy, a path for pharmacy technician trainees to work in a pharmacy in an official capacity under education. So pretty easy proposal. So simple responses drafted. Members? I don't see anyone, so we're moving on to issue number 11. The board's statutory proposal recommending clarifying changes to provisions for pharmacies operating under common ownership. I also want to make sure you're comfortable with the draft statutory language, which is included as an attachment. I think that this one is again, just kind of continuing on the issue. I think we're at enforcement issues, issue number 11. Members? Okay, I'm hearing your silence is in agreement with the response we've drafted. Next is issue number 12. To the sunset standard of care model for pharmacist practice. We had a very lengthy and robust discussion for the last 3-4 years. We've created a committee. This is such an important issue. I feel very strongly, and I think what's going on in our country, this is a more important issue more than ever, because this would, provide some really great opportunity for pharmacists. And what reminded me today during Dr. Shane's presentation, as well as Cherie Lowe's presentation today, is that, pharmacists can really help preventing admissions to EDs. And I think that will save health systems so much money. And if members are agreeable, I'm hoping that could be also included in the response that, I know that maybe there's no study to present, be a definitive, but I'm confident that pharmacists can really help prevent readmissions to admissions to EDs, especially hearing about people needing inhalers for their asthma, uncontrolled asthma or uncontrolled diabetes. I think pharmacists can really help with that. So I know this issue has a long topic, lots of topics. Another thing that I want to highlight maybe is for us to consider. I know we kept the comments very broad, so I don't think that it needs to be included, but I think that maybe we can consider talking about some vaccines and how we could hopefully provide more flexibility for pharmacists to provide vaccines thanks to standard of care. So members, any thoughts?
Sung, this is Marie. I have a question about process.
Yes.
I know that in the volume 2 is going to be the statutory proposal, but I believe we still had some wording to improve upon the statutory proposal. Is that something that's going to come back to the board to detail that before we look for a sponsor? Or what's the next steps on that proposed statutory proposal? Because we didn't finish the discussion about some of the detail.
Thank you, Maria. So I think, unfortunately, the way that the sunset process, it kind of, this is where you could give me and Anne some ideas. So the way that the sunset process works is really, the ball is up to the legislators. So, we put as much as what we can, and it's up to them to, take on. And from there, the negotiation process goes on what we will be able to have. So, Anne, do you want to add anything to Maria's comments? So unfortunately, the answer would be that we won't be able to really review. I mean, as the AB 1503 discussion goes at the Legislation and Regulation Committee, there will be probably an opportunity for all of us to provide input, is my hope. But this whole process usually is really the legislators. So Anne, go ahead.
Yeah, and I think as part of the board's original action in this area, I do think that it was kind of delegated to President O to finalize some of these pieces to meet the submission deadline.
Thank you, Anne. But Maria, I think to your response, I'm hopeful that like as 1503 comes up for discussion, that we can see, because we don't even have the text of the law that they are putting forward, and we don't know what's going to go on there. So it's really kind of hard to, yeah.
Okay, so just as long as, I had two concerns that I'd submitted to a couple of the committee meetings, and those didn't get discussed. The one that was most important is our current regulations require that the pharmacists follow ACIP guidelines for providing vaccines. And that was not included in the language. So maybe at some point during the discussion and amendment, that those minor amendments could be, they're very detailed, I mean, very small, but it's also different than what our current regulations say about providing vaccines. So, and there was one other point, but I don't remember what the other point is off the top of my head.
The ACIP one, Maria, I know that I specifically remember including that in our amendment to the legislator. That I'm pretty certain we did include that.
Okay, so maybe and when the final report is done, I'll look specifically at H10 more closely.
Yeah. So hopefully we'll have the language posted on our not our website, but on the legislative website for AB 1503. As soon as it's up, I'm sure Anne will email everybody to let them know what is included as well. Any other comments for members on standard of care response?
Sorry, President O, it's Ann again, just really fast. So we could update also the response to call that out specifically as an example.
Perfect, okay.
Sorry, can you clarify what you mean by like ACIP guidelines? Like you want that to be included or you don't want it to be included?
I just wanted to match what our current regulations are. So it gives some parameters as to what vaccines, what tools a pharmacist should use to provide vaccines instead of necessarily following only package insert or manufacturing guidelines to determine whether to give a vaccine, but that the recommendations should come from the national CDC via their ACIP group. So that's what's in current regulation.
Got it. So just to maintain it. So I wanted to add, I brought this up previously, I think to discuss as a future agenda item. And I know previously I've been in support of keeping the ACIP guidelines. However, given the current climate of the federal government and the real possibility of ACIP guidelines being removed at some point, I think there is a real urgent need to not have our regulations tied to a federal agency and to allow for more flexibility in that. And so I would actually, I would prefer having a change because I mean, overnight we could go from our pharmacists not being able to administer vaccines at all in California, which would be devastating. Additionally in that, I mean, I've said this a lot, obviously, but in terms, I think the responses, let's see, what number are we at? We're at 12, right? I think the responses are very good. It's very thorough. In addition to the response to the staffing, I think one of the issues that comes up a lot when I hear pharmacists is not only being understaffed, but if you're in, I don't know the right phrasing for it, but if you're one pharmacist working in a setting, you really can't be providing these clinical services while you're verifying prescription. It really should be like a one or the other thing, which is why previously I had made the recommendation of having 2 pharmacists staffed in a chain retail setting if they were providing these services. And then on top of that, it's just I think one of the other concerns that's brought up multiple times is the fear of retaliation. Even though we have language about autonomy for pharmacists and we have new law in place to stop people from, stop entities and licensees from putting pressure on pharmacists, I'm not sure that we have the data yet to see how that enforcement looks. And I think that's still a really valid concern before we continue expanding the scope of practice for pharmacists in a chain retail setting. But curious to see what everyone else thinks. I really hope that we can get in some sort of agreement on just not tying the clinical practices to one entity. I think that's really important and evident with the climate in our federal government right now.
Thank you, Jesse, for the comment. So is there some way that we can maybe balance that? So I completely hear Maria and you, Jesse, and I agree that it is a very challenging topic because I think a lot of, I'm not following so closely, so I don't really know exactly what's going on with ACIP. So, but I know that it's been, there's just been some concerns with that. So do we have any information on that, Anne? I'm not really following too closely, but it would be nice to, in some way, tie ACIP as a recommendation, but be able to delink it if possible. That
Yeah,
would
I
be
wonder if
probably
we could
what I'm
maybe have
thinking.
language that has the recommendation of ACIP, or if those guidelines aren't available, maybe have language
Yeah.
to say, or current practice, or I don't know, but some language, maybe someone can think of something better, but, or standard clinical practice if unavailable.
Maria,
I'd be
how's that
I'd
sound?
be happy with that if the president and Anne would work on that, that if it's not available, that it be that or. Because my concern is that if we're solely following approved vaccines and that are approved by the FDA, that we could be providing vaccines that are over and beyond
Yeah,
what
the
ACIP
schedule.
approves. And so our goal is not to vaccinate everyone for everything, but to vaccinate things that are the most important, that are determined by an independent body and not the
Right, yeah.
manufacturer.
Yeah, so should it be helpful? So the language does reference initiate or administer any FDA-approved or authorized immunization for persons 3 years of age or older, consistent with ACIP practices recommendations. So that's in the language right now. And then, so what I'm hearing is we could update the regulation or the response to indicate that ACIP or a similar approving body, something along those lines. Like we can call that out as, okay.
I would say, or just making it clear that if the ACIP guidelines are unavailable, yeah.
More generic, because it could be the American Pediatrics Association, or it could be another group. So I don't think we need to be so prescriptive.
So I think again,
You guys
but
can work on that. I think you can work on
yeah,
that
and then
line.
I will just add, I think this is where the beauty of standard of care can really come in and help, right? Because any prudently educated pharmacists with the same knowledge or skills and abilities who understand vaccine should really have some good idea of the vaccine schedule as their education. So the hope is that those pharmacists would be able to really know what they're doing. Now, if the ACIP guidelines are not available, I mean, some pharmacists may get lost. And in that case, those pharmacists shouldn't just do something because they're corporate entities telling them to vaccinate hepatitis B, whatever it is. So I'm hoping that there can be some, I think the flexibility is the key word, hopefully, and going forward in this concept of standard of care.
Yeah. I just want to add one thing while we're on the topic of vaccines is even with ACIP guidelines, I still see confusion and hear pressure from corporate entities and corporate pharmacists really stretching the recommendations on some vaccines and putting pressure on their pharmacists to administer vaccines that they really shouldn't be recommending to their patients. And when they get pushback, they're not able to really have a dialogue or really practice. And so I just want to point that out there. And I agree with Maria, there really needs to be a body, because without some sort of structure, I think that should be like our first point of recommendation and reference. And then, you know, just as a backup in case it's not available, then we can expand it from there. But I've seen the lines and guidelines stretched very thin when it comes to corporate pressure for vaccine administration.
Thank you, Jessie. Okay, members, do we have any other thoughts? Okay, we are ready to move on to issue number 13, the recent topic. This is the self-assessment proposal. Very simple. I think it's a great idea. Don't know why it took us this long to not have thought about this, but finally it is here. Hopefully this will make it easy for us to move forward. I don't think it's controversial, so hopefully we can move forward on that. Members? Don't see anyone jumping up there for microphone, so we're moving to issue number 14, statutory proposal to improve regulation of non-resident pharmacies. Members? Again, I know this issue we've discussed ad nauseum for many years, so I'm guessing that we've, you know, that's good to go. So I don't see any. Next issue is issue number 15, is related to the proposal to secure increased fine authority for mail order pharmacies. Members? Silence as your agreement in the response. Okay. Issue number 16, related to the discussion and proposal related to online health platforms. Again, we kept it very generic here. We just want to ensure there's some conflict of interests that are hopefully protected for patients' choice. Issue number 17, related to the board's statutory proposal to address some payer practices compromising patient safety. Members, any comments? We've discussed this also for a long time. Okay, number 18 is related to the board proposal to update the current requirements for pharmacist furnished medication assistant treatment. Again, very non-controversial issue, so all right, we're gonna go ahead,
I'm
Nicole.
sorry.
Yeah.
I'm just kind of commenting on this, very similar to what Jessie was talking about in number 7. We referenced specifically SAMHSA guidelines. SAMHSA doesn't exist anymore as of last week. It got incorporated into the new Administration for a Healthy America, or whatever it is, AHA. So I think we need to, in any of our guidelines, kind of that reference one specific thing with what's happening at the federal government, we need like maybe another statement that says, or current best practice, or just, there has to be some other alternative, because it's the same problem here.
Thank you, Nicole. That is excellent comment. Okay, next issue is issue number 19, related to the board's proposal to update the pharmacist to pharmacy technician ratio. Of course, this is like, we kept the response very brief, but something we've discussed for a long time. I think it's a very adequate response.
President O?
Yes.
I do really like the response, but I think one of the things we talked about as we were dealing with the statutory language was that in the future, having discussion, I mean, we kind of mentioned here about different practice models, but it'd be nice to really call out hospitals in some way. You know, talking about the other outpatient models are here, closed door, central fill pharmacies. But the point that we said that we were going to come back and circle to was looking at ratios for hospitals. But given this authority, that could be part of that. But so it'd still be nice to mention something about hospitals.
Okay, I thought I I for some reason thought that we already included that this is the authority we already have for hospitals, but maybe if we didn't mention it, I'm sure that's an easy add that we already have current authority to adjust the ratio for inpatient setting.
So I may be
So
mistaken that we do have the legislative ability, and maybe that my thought was that, or my misunderstanding was that the board is going to address the hospitals, and maybe it's not a sunset issue, because if we have the statutory authority, then I just wanted to assure that that topic was going to come up in the future.
I think you're right though, Maria, that I don't think we actually added that statement. So I'm sure we could add a statement that what we're trying to do is basically mirror our current authority to for inpatient settings. So thank you for bringing that up.
Sung, I actually think I think the language actually addresses it. And the last area there, I see it says inconsistent, consistent with the board's authority to establish the pharmacist to technician ratio for inpatient pharmacy settings.
Oh, okay.
That's pretty,
Okay.
I think that's
Okay.
clear enough for me. I don't know if anyone thinks there needs
Okay.
to be additional changes.
Oh, okay. I
Under
see
the-
there. Thank you. Yes,
I
thanks
think
for
it's
pointing that
the
out.
last sentence,
Yes,
second to last
yes.
sentence
Okay, perfect.
for the
Thank you,
board's
Jess.
response.
Okay, thank you. Great. Awesome. Next is issue number 20 related to related to the board's statutory proposal to expand provision for pharmacy technicians who work outside of a pharmacy while under the direct supervision and control of a pharmacist. So, again, our response is very simple, clear, I think. Any other suggestions or thoughts? Seeing none, we're moving forward and to issue number 21 related to the board's statutory proposal related to artificial intelligence being pursued to ensure the autonomy of pharmacist practice. We kept it simple. As you can imagine, AI is a very controversial topic. Okay. We're getting to the less controversial issues. Issue 22 related to the board's proposal to allow for digitizing pharmacy records. I think the key word here is digitizing though, so I'm sure we'll have a lot of educational effort to our pharmacist who's going to want to do that. But that's not for discussion today, but I think it's pretty simple response. Okay, issue number 23 is related to the board's compounding regulations. We had significant response and an engagement from the stakeholders. So we really wanted to provide a very thorough explanation, the history and everything in between for compounding regulations. Sure, we have some comments on here. So members, how are you feeling with the way that we approach this? If we just hit it out of the park, that's okay too. I know Anne and I, well, Anne mainly, worked very hard to draft these responses. I know on many, many Sunday nights, Saturday nights. So, okay. No response, no comment. All right, we're moving forward. Okay, issue number 24, related to the board statute proposal related to compounding by adding a flavoring agent. Again, this one, we kept it, we try to provide some history, but also keep it simple. Okay, issue number 25 is related to the board's remote processing statutory proposal. Members?
Hi, Sung, this is Jessie. This is for the remote processing, right?
Yes, issue number 25.
Sorry, I think I wanted clarification. I thought during our discussions when we talked about remote processing, we did discuss the need for certain settings, not generally community settings, but for items like specialty. But I know it's been a long time since we discussed it. So I just wanted to clarify that because the response, it says is also appropriate for community settings. So maybe my recollection isn't correct. I just wanted to.
So from our discussion, which was this was a very contentious issue like 2, 3 years ago. From where we landed was actually not limited at that time, but just to continue the kind of the proposal as it is. And at that time that we did not want to limit it to a certain set of it. That was something that we did not have a consensus on to limiting it. We are just continuing on with where we left off. And if this becomes an issue, I'm sure, the legislator would address it. But this is again, kind of a neutral response to where we landed from what decision we made.
Got it. Thank you.
Okay. Thank you. Next is issue number 26 is a new issue. So this is a new issue being raised by the committee questioning if there should be greater distinction between community pharmacies and health system pharmacies. So this is a question that I think we could leverage as providing some more, if members are agreeable, of what Dr. Shane's presentation today. I'm hoping that we could add and would allow me and Ann to work together, Ann and I to work together to provide some maybe an opportunity also that there's a possibility for providing discharge patient education by pharmacists, if members are agreeable.
Hi, Sung, this is Maria. I agree with what your comment is, but I was also going to comment that I like the response and that it's very limited instead of including the larger perspective. I would be very much against having separate regulations or separate laws for each practice setting. And my specific example of that is years ago, sterile compounding regulations were written in such a way that there were silos, and that caused a lot more issues than it helped. At that time, there was an opinion that it would be better to have silos and to have specifically that separated out and not integrated with exceptions. And so I want to go on record that I really am opposed to having separate laws or separate regulations for the different practice settings. I think they can all be addressed separately without having different regulatory sections or different sections of the law. But I do agree that they need to be, each of our practice settings need to be addressed, but not addressed in separate laws.
Thank you, Maria. I actually am in agreement with you on that. So thank you for the comment. Any other? Go ahead, Nicole.
Yeah, this is Nicole. So I wanted to add to this, in addition to health system pharmacies, I just wanted to bring up clinics that have a pharmacy associated with them. They're not specifically health systems, but and I get your point, Maria. I think should be completely siloed, but those of us that have a pharmacy that's associated with a medical practice, health systems, clinics, things like that, we're put in as community pharmacies. But there are some ways that we're closer to a hospital. Like our doctors are there. We have P&T committees. We work with our CMO, but we're stuck under the rules of a community pharmacy that sometimes get in the way. So they constantly kind of bump up to the point that it's become like a running joke at the clinic. They're always like, why can't we do it because of pharmacy law? And so it limits our ability to do the best work for our patients because we have to act as if we're a totally separate entity when we're one legally owned. And it's very confusing legally because we're a federally qualified health center owned and licensed by the same thing, but licensed separately for the pharmacy. So I do think there needs to be something in between just community and hospital. There is a place in between that we don't account for that shoves us into a box where we don't totally fit. I know we don't want to make more things and make it more complicated, but it does cause a lot of problems for us. And I would also think a self-assessment for those kind of groups would be really helpful because there's a lot of sections on the community one that don't apply and that something else would be more appropriate.
So I think we're kind of saying the same thing. And what you're advocating more is for a different license category. And I would have no problem having, not everybody is a PHY. One PHY is different than another PHY. And I think that would be a very interesting discussion in the licensing committee to say, does PHYs need to be broken out a little bit more and be different? But I'm looking at, but looking at the structure of the law and the regulation, I wouldn't want to have separate law books, for example. But I totally agree with you. There's value in having the discussion about license categories.
Yeah.
We kind of do that already in hospitals where licensed sterile compounding is not in the hospital. It's a separate licensure.
Yes, exactly. That would be helpful. And I think there was some mention of a potential ad hoc committee. I wanted to volunteer if that happens as like a representative of like the clinic community.
Thank you, Nicole. I think that this is exactly why we've drafted our response in some ways that it requires our evaluation. And I think it requires our discussion. I think I would just say that maybe we could say that this is not a decision that should be done at this level by the Sunset Committee, but more something that board can further discuss because we could really dive into these, layers of it, such as license category, but also the relevance of the laws and regulations. So I think our response as drafted, though, I think covers our discussion in large part. So hopefully that is correct assessment from what I'm hearing.
Yeah, I think the response is good. I just want us to deal with the issue separate from it. Sorry if that wasn't clear.
Okay, thank you,
Sung.
Nicole.
It's
Go ahead,
Jessie. I agree with Nicole's comments and Maria's comments. I think there's a real opportunity to maybe create this ad hoc committee that's not necessarily limited to the health systems pharmacy, but really helps create this platform for these unique settings and really helps the board get better engagement and better insight into the issues that they face specifically. So I think this is a good opportunity and I appreciate the response from staff.
Thank you. Sorry, Ann. I guess seems like the wave of the feeling is to create another ad hoc committee. So we'll talk.
I mean, I'm not been proponent of another ad hoc committee, having been a part of an ad hoc committee. I'm thinking that this should start in licensure and then they can determine what the next steps are. That's my opinion.
Okay. Okay. All right. Okay, I know Jeff has to leave at 2:30. Thank goodness we did the Nicole quorum motion, so we're safe. But we'll plow through here. Jeff, if you do need to go, just let us know. And then thank you so much for your participation as always. But hang in
Sung,
there
I think
as long as you
he
can.
is still here for now. It sounds like he's
Oh,
making
yay,
his way.
that's good. Okay, that's good. Okay, so we're moving on to issue number 27. Now, these are all under equity issues category related to the board's statutory proposal to waive application fees for a pharmacy that operates in a medically underserved area. The one thing that I want to bring up to members in this is that there are also urban pharmacy desert, not, we think of a pharmacy desert as literally desert, like rural, but there are a lot of urban pharmacy desert that are forming as well. So I'm hoping that if you all are agreeable that we would like to at least let the committee know that that's something, it's not in our statutory proposal that we put forward, but it's something that we should consider some further discussion if they can come up with some kind of resolution related to urban pharmacy desert that are forming, like in San Francisco, like in Los Angeles, very underserved areas that looks like it's not rural at all, but there's no pharmacies because these are highly, just very underserved communities. So members, what are your thoughts on that?
Hi, Sung. It's Jessie. That's a good point there. And I think, sorry, my document is not loading. It's a huge document, so I can't actually pull up the report right now. But I did put some notes there. Just some notes here, like what does pharmacy services mean? I think that's something that needs to be clarified in the language. I'm not sure if that's supposed to include clinical services or just traditional dispensing services. And then there was also just clarification on if we specify, is it just like a specific license type, or are we, providing clarification if it's open door or closed door? And maybe that was the intention of pharmacy patient services, but I think we need to really iron out the definition there. For me, I don't think the language is where it needs to be just yet. And so I'll leave that there. And I think you bring up a really good point about pharmacy deserts in that it's not just in rural areas. And hopefully we can add a little sentence about that too, just to make sure we're acknowledging it.
Okay.
This is Nicole. I agree, especially about the piece about pharmacy deserts. In urban areas, we know they tend to disproportionately impact communities of color and lower income neighborhoods. So maybe if we can reference that as well. The one thing I wanted to bring up, and please don't be mad at me, Anne, as more than the money, is there any like expediting the license to this? That almost seems the more impactful to me than waiving the fees, is to get the license out quicker. I know it's hard. I know that's a big ask, but was that considered, or is that a possibility?
So that's actually part of the proposal in the original report, where we will be having staff dedicated to help licensees through the process.
Okay, good. Anne's not mad at me. Okay, thank you.
Sung,
Okay,
this is
members.
Maria. I
Go
was
ahead, Maria.
thinking that there might be an opportunity to include an attachment or some additional information or a footnote link. I believe that Dr. Stephen Chin in Southern California has a map of pharmacy deserts that include urban areas. I'm not sure if that map is just Southern California or if it's the entire state, but I remember the first time I saw that map, I was taken aback. It is, like I say, a picture is 1,000 words.
Yes, and I think for legislators, the pictures are very helpful because it's just kind of impactful to them, because these are all very complex issues. So okay, that sounds great. I think we can definitely incorporate that. Any other suggestions, thoughts? Okay, we're ready to move on to issue number 28, related to the board's statutory proposal to allow for pharmacists to furnish OTC hormonal contraception. This is a very simple issue. I think that we kept the response simple because it also would be resolved if the standard of care proposal goes forward. So issue number 28.
Just a quick note that we will be updating to indicate that the board has taken a support position on AB 50 because that happened today.
Thank you, Anne. Okay, moving on to issue number 29, related to the board's technical cleanup related to the board's patient safety measure AB 1286. Only comment I have is that we would like to make sure that members are agreeable. I know that someone during the self-assessment discussion brought up the wording of the store management. Maybe that's another thing that we could convey, but that I think can be done offline. But I think we may need to, I don't know if that needs to be in the board's response, so just keep that in mind for members.
Hi, Sung. This is Jessie. The one question I have, and this kind of goes back to just what I had alluded to in the standard of care discussion, is I would be curious if we have any information about complaints or citations in regards to entities that may be pressuring pharmacists to perform services. I don't think we really discussed that at all. So I would be curious to see if we have any information on that yet.
Okay. Is there anything that we could include that into? I don't think there's anything into the response. I think that's more of our future discussion, right? So I don't think there's much to add on.
Right, for clarification. And yeah, I guess not. I guess my perspective on it is I think that information is useful if we're determining if there needs to be changes to the language. I think we need to have some information about whether it's being followed or whether we have any information on it so far, but I'll leave that up to you and Ann to decide if you think it should be included or not.
Okay, thank you, Jessie. Any other comments on the issue number 29?
I would just like to make a formal comment about that. I think that that would be better served as a separate agenda item and discussed by the board rather than potentially cause challenges with the sunset bill and the sunset discussion. Because I think that we need to fully flesh that out. And I'm sure there's going to be lots of discussion on all sides. And so I think that that would be a wonderful agenda item for, I don't know which committee, but a future meeting. For me?
Licensing, you think?
Because they're doing the survey.
Okay.
The resurveys happen, or just happened.
Great.
And I cannot hear you. What are you saying?
Oh, and was just saying that it may be appropriate for licensing since
Oh, okay.
we'll be going
Okay.
through the survey.
Got it. Okay. All righty. Issue number 30 is related to the board's proposal to update records requirement. This is pretty non-controversial, but so we kept it very simple. Okay, I don't see any response on there from members, so we're moving on to 31. We're almost there. We're so close. Issue number 31 is an opportunity for the board to provide oversight committees with additional cleanup amendments. So this is where things just wind down. So issue number 32, the last one, is a recommendation to continue the board's current regulation of the pharmacy profession. Of course, we're gonna say yes, but be a plot twist. We say no, thank you, and move on, and just drop the mic and go home. But that's not gonna happen. So that is the last of it. All right. Now, having gone through all these issues, unless there's any other comments from members, this is the time that we would need a motion. I know the draft motion is included in the meeting materials and hopefully will be on the on the slide. Don't see it yet, but I'm more than happy to make the motion actually for this item because I make a motion to approve the draft responses to the sunset issues raised by the Legislative Oversight Committee as consistent with the board's discussion and delegated to the board president the authority to work with the board staff to finalize responses, including attachment thereto for submission to the Oversight Committee. And I'm in need of second, members.
Second.
Thank you, Trevor. Appreciate it. Okay, members, any comments before we go to public comment? Okay, I think we've talked ad nauseum, so we're ready for public comment in Sacramento. Did everybody leave? Is the room empty?
We have a couple people here.
Okay.
No public comment? No. We don't have any public comment in Sacramento.
No public, okay, all right. We're ready for public comment in WebEx.
All right, this is the moderator. If anyone would like to make a comment on the sunset actions responses, you may look for the hand icon and click that to raise your hand. And our call-in users can press *3 to raise their hand. Each speaker will have 2 minutes with a 10-second warning, and we ask people to speak only once per agenda item. We do have a request from John Gray. John, I'll send you a request to unmute, and you'll have 2 minutes.
Hi, good afternoon. Yes, thank you. This is John Gray, registered pharmacist with Kaiser Permanente. Just wanted to address the discussion on item 26, question around distinction in law between different practice settings. I found Member Thibault's comments on how pharmacies situated in clinics can operate very differently from conventional kind of community pharmacies. And I would highlight that Kaiser Permanente's pharmacies that operate in our medical office buildings often look like a chain community pharmacy and are subject to laws that apply to chain community pharmacies, but in many situations operate very differently from chain community pharmacies. For example, in California, our pharmacists within our medical office building pharmacies don't administer vaccines, right? Because we have physicians' offices and nurse clinics in the same building. So some of the time pressures and other pressures that pharmacists might experience in other practice settings may not be there in all practice settings. I'll also note that some board members expressed concerns about having different laws and regulations for different practice settings. I would just point out that there are already many laws and regulations that apply only to certain practice settings. For example, there are many laws and regulations that apply only to chain community pharmacies. The board is also proposing in this sunset review packet a statutory change that would address fining authority specific to mail order pharmacies. So just again point out that to some extent those things already exist. So, given all that, I think our bottom line is that, we look forward to continuing this discussion at a future committee meeting. So thanks very much for the opportunity to comment.
Thank you for the comments, Dr. Gray, as always.
And I do not see any. Oh, no, I absolutely do. My apologies. So Keith Yoshizuka, you are next up. I will send you a request to unmute and you'll have 2 minutes. Go ahead.
For the opportunity to comment. Keith Yoshizuka,
Yes.
California Society of Health System Pharmacists. During the discussion about the pros and cons of whether to add a pharmacy technician to the Board of Pharmacy, the CSHP endorses such an action. Thank you.
Thank you for the comments, Dr.
Thank you.
Yoshizuka.
And our next request to speak is from Paige Talley. Paige, I'm going to send you a request to unmute and you'll have 2 minutes. There you go.
Yes, Paige Talley with the California Council for the Advancement of Pharmacy. And I just heard what Yoshi said, Keith, and I agree that I think also a pharmacy technician would be great on the board. But my purpose for first raising my hand was to say that we need to remember that health systems aren't the only ones that are already regulated by law. And long-term care for skilled nursing facilities can have up to 2 pharmacy technicians per 1 pharmacist. However, they don't typically do this because they serve congregate living people and individuals, ALFs, and they can't mix them. They would have to do the nursing facilities first or second, and then the congregate living facilities next. And that's just cumbersome. It's too much trouble. So I agree with Dr. Serpa that we should not have all these silos for licensees. However, we do need to remember that long-term care is a closed door pharmacy and they should have more leeway with pharmacy technicians than they do already. Thank you.
Thank you for the comments, Paige.
And our next person to comment is Stephen Gray. Stephen, I'll send you a request to unmute and you'll have 2 minutes. And Stephen, I'm going to send one more. Oh, there you go. You got it.
Thank you very much. There seems to be a little cyberspace delay here. I would want to comment on the concept of overall concept of to be aware of unintentional consequences. And I'll go back to the first part of the discussion where the bill that is going to be the sunset bill talked about designating an advanced practice pharmacist to an advanced pharmacist practitioner. The word practitioner is a term of art. It has specific meaning in many different laws, both at the state level and at the federal level. And when you call that the advanced practice pharmacist license today is now a practitioner, what does that mean for a pharmacist that is not an advanced practice for the RPH today licensed pharmacist. There are certain things in law that say can be done by a healthcare practitioner. And if you designate the advanced practice as a practitioner, where does that leave the RPH pharmacist? And I would encourage the board to ask counsel to do that research. Second, in the cleanup amendments in number 31, I suggest putting that off till next year and organizing a group to talk about cleanup. There are a lot of things in California pharmacy law that need to be cleaned up. Some that are no longer applicable, a few that are actually against federal law. And so for an omnibus bill, we call that in a regular year, an omnibus bill, that would make something that could be worked on by a special select group and with board staff for next year. And then we could clean up some of these things that are confusing. There are, for an example, any order from out of state of a Schedule II item is supposed to be immediately reported to the Department of Justice. But when they did that, they asked us to stop reporting those purchases. But it would be in violation of a statute if we didn't report it. Thank you very much.
Thank you for the comments always, Dr. Gray. And if you do have a list of things, please let us know. But I think that's a great suggestion next year moving forward. So thank you.
Our next request for comment is from Max. And Max, I'm going to send you a request to unmute. Go ahead.
I just wanted to second that comment about distinguishing between advanced practice and RPH is what I really wanted to say. Thank you.
Thank you.
Thank you for the comment.
And at this point, I do not see any further requests. Shall I close the public comment feature?
Yes, please. Thank you, everyone, for the comment. And
President,
members.
we do have public comment here in Sacramento now.
Okay.
Thank you.
Thank you. Oh, Dr. Kim. Okay. Yeah, I was wondering if he's gonna speak on this issue. I was surprised he didn't speak. So I'm glad. Thank you. Go ahead.
Sorry, it took me a while because there were so many items. And first of all, thank you so much for discussing all these items. I think it's very important. Just wanted to talk about one thing about standard of care, looking at the proposed language. As we discussed about ACIP and SAMHSA, there are a lot of moving parts nowadays, more than the past. I think we also need to think about the flexibility of our practice because of, at the end, it is the consumer protection at the readily as possible for any changes shouldn't be the barrier for patient care. With that note, I think it is very important to include the language of general approach for standard of care. Things that we should ask on. Number one, is this prohibited by the chapter or the state or federal law? And number two, is it within the licensee's education, training, and experience? And number three, is this under standard of care? With that, we can think about the unprofessional conduct. If anything is against to those three items, then it is fair to say this is not under standard of care. So it gives the flexibility of practice of pharmacy at the same time for to consider if it is under standard of care or not. At the moment, it is missing piece in the proposed language. And if there's any help that we can provide as CPHA, we're more than happy to help. So thank you again for considering, and thank you again for all the work with the Sunset Review. We applaud.
Thank you for the comments, Dr. Kim. All right, members, I think that is it in this item. Before I call for vote, do we have any final comments? I'm sure everybody just wants to go home, so I understand. Okay, members, we're ready for vote. All right, Jesse?
Yes.
Thank you. Trevor?
Yeah. Yes.
Thank you. Renee?
Yes.
Thank you. Jeff?
Yes.
Jeff still there? Oh, yay, Jeff. Jay?
Yes.
Thank you. Ricardo?
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you. And I vote yes, the motion passes. Thank you, everyone. Look forward to the continually informing you of the progress we make on this wonderful sunset item. So I'm sure we'll be talking about this as we move forward, and we'll keep all of you posted as more informations are available to us. Alrighty, next agenda item is agenda item 17. It's our executive officer report, and you need to talk a little slow today because you always talk so fast. So Anne, the floor is yours. You don't have to be so fast.
So just a few items. The first is licensing statistics because licensing was canceled to accommodate the regulation work that needed to be done. Wanted to ensure that members and the regulated public had an opportunity to see the updates to the licensing statistics, so they were included in the meeting materials. Also, we referenced in there the exam statistics, so they were not quite ready at the time. They have since been released and also provided to the schools of pharmacy. Specifically regarding the CPJE, the overall pass rate during the period was 51.95%, which is very consistent or very close to what it was for the same time last year, which was about 52%. California schools had a slightly higher pass rate than other U.S. graduates. Just want to highlight that this is kind of like the off season of examinations, right? We've typically gone through a lot of the recent grads and everything else in the prior reporting period. The NAPLEX, the board displays the NAPLEX scores for people that took the exam during the same time as the reporting period for the CPJE. So it's not a full apples to apples, but we provide this information. It is required as part of Sunset. So this is how we report the information. But the overall pass rate for the exam for like how we have captured it was about 71, almost 72%. California schools did have a slightly lower pass rate when compared with the other ones. Next, just wanted to let you know, I had reported last time about the transition to the online renewals. We continue to have good success there, but regrettably the hiccup that we have, it's a very small percentage of, it impacts a very small percentage of pharmacy technicians and pharmacists that renew online, but we do continue to try to find a solution with the Department of Consumer Affairs and its contract. In the meantime, we have a manual process that we are using to resolve those few online renewals that have a bit of a challenge. Just another quick reminder, we talked about it before. Debbie, if you could go to the next slide, please. There is an increase in the cures fee. This is not a fee. This is assessed by the Department of Justice. We collect it through the renewal process, but it's not money that goes to the board. So with that, we have done some education. So this slide just shows kind of one of the notices that we sent out on X. We also sent out subscriber alerts. And then on the last one, Debbie, if you could go to the next slide, please. Medication error reporting. This is, we've talked about this through implementation of AB 1286. The board had approved the Institute for Safe Medication Practices to serve as the entity approved for receiving medication error reports. Since that time, we have been moving through both the contracting process as well as implementation. So happy to report that we are getting close to releasing information and getting beginning the registration process through ISMP. So what you see on this slide, we will be sending out a subscriber alert advising all of our licensees that are impacted by this to watch for a postcard that will be sent out from ISMP that will include information. We will also try to have some very quick information on our website. And then as our implementation activities continue, it is anticipated that the Enforcement and Compounding Committee will be looking at the AB 1286 FAQs and updating them as appropriate to reflect that the next implementation phase specific to the med error reporting. And that's my report. Thank you.
Thank you, Anne. Again, through bulldozing through your items, big news there. I think that med error reporting is an important topic that I think we'll just need to remind our licensees it's still coming. I'm sure it just needs constant reminders. So I think those are good. Thank you. All righty, members. Do we have any public comment or member comments first for Anne before we go on to public
So,
comment.
Sung, I have two things.
Go ahead. Yes.
Thank you, Ann, first and the entire team for everything. I was very, very interested reading the pass-fail rates because there's less than a handful of universities that have a exponentially higher fail rate than others across the board. I'm just curious, and I know nothing about these universities specifically, but when I see 72, 75, 60, 62 consistently on both, that concerns me as far as those institutions. What engagement do we have with these institutions? It just that the fail rates for these specific ones really stood out to me.
Yeah, so I guess a few things, if that's okay.
Mhm.
We don't have a role in approval of the schools. That's
Right.
done through ACPE, and we're super fortunate that there's a single accrediting body for for pharmacists, right? That's unique. So we don't necessarily have any say over school approvals. What I would say is that this is kind of like an off-cycle time frame.
Mhm.
So it may be helpful to look at like the Sunset Report where there's more aggregated information. Some of the data sets are really small.
Yeah.
So I don't know that you can provide a huge amount of meaning to it. You know, when you have
Okay.
two people that take it, is it a function of the school? Is it, off, it's just that, there wasn't enough people to take it. And so the data looks a little funky because of that.
Okay.
And funky is a technical
Yeah.
psychometric term. Psychometric term.
And second, one thing that just popped up when you showed the X, the tweet, whatever they're called now, is to my knowledge, I don't believe the Board of Pharmacy has a presence on LinkedIn. And given the fluctuations of all the different social medias, the one that has seemed to remain the most stable seems to have been LinkedIn. And it would allow the board to have a greater target over people who self-identify on their LinkedIn as pharmacists or within the pharmacy community. I don't know if this needs to go through the communications committee, but I just wanted to put it out there that I think a really effective way potentially of communicating in a targeted way towards self-identified pharmacists as another redundancy would be LinkedIn. So I just wanted to put that out there because I saw a tweet and made me think of.
Thank you, Trevor. That I actually, and I didn't want to be killed by Ann Sodergren, so I didn't want to say anything, but I was hoping to find a way to get off or at least have an alternative to X. So
Yeah. So first of all, I'm not a violent person. So let me just say that first of all. But the chair of the Communication Public Education Committee is here, so we will make a note to include a discussion if the chair is agreeable on the use of social media and where we maybe need to pivot.
And
yay, thank you, Ann.
President O just had a couple of comments on there. I'm not sure. Does DCA have a policy about social media? And that's probably something that the communication committee would be more familiar with. And just for, I'm sure that Trevor knows, but if he doesn't, all licensees are required to have emails in their, to notify the board of their email. So that's another method. When you really need to get it out to the licensees, it goes through the email portion. 100%. Thanks.
Related to the pass rates that Trevor was mentioning, I think something that we can do from the board level moving forward is maybe having a future agenda item. One thing that's consistently comes up in my discussions with pharmacists when we talk about the changes over time of interns and the pass rates and trying to figure it out is a lot of us, and I'll speak for myself. When I was in school, I had to do some work requirements, and in order to be employed, I had to work a minimum number of hours a week. This was pretty standard, and in order to graduate and get a job, you need a job experience, and so that it was much more competitive. I will say there were limited spots, but I think it's something to consider, maybe as a board, having a discussion about the work requirements while people are in school. Well, I think obviously it's important to pass an exam so that you can practice. There is just so much that you learn from work that you cannot learn from a textbook. When you can put a face to a condition and to medications, it just makes you a better practitioner overall. I feel like the information just sticks better. And I do see that my interns who are working consistently through school are more successful on their exams. And so I would hope that we can have that discussion more moving forward.
Absolutely. Thank you, Jesse. Okay, any other members? I think we're ready for public comment in Sacramento. Do we have anyone?
We do.
Oh, perfect.
Just wanted to add to
No
Trevor's
running, Sean.
comments.
Cannot allow.
No, I wanted to say thank you for joining us at the CPC meeting. President O and we're with the 14 school pharmacy deans, and then having ongoing discussion. This really helps to foster the future of pharmacy profession, and we believe that we're on the right track to having the conversation, talk about some of the interns and pass or fail rates. So we appreciate as an association. Thank you.
Thank you, Dr. Kim. Okay, we're ready for WebEx. Moderator Ann.
This is the moderator. If anyone would like to make a comment on the executive officer's report, you may look for the hand icon and click that to raise your hand. And our call-in users may press *3 to raise their hand. Each speaker will have 2 minutes with a 10-second warning, and we ask people to speak only once on each agenda item. We do have a request from John Gray. John, I'm sending you a request to unmute. You're unmuted.
Thank you so
Go
much.
ahead.
Thank you. Yeah, this is John Gray, registered pharmacist with Kaiser Permanente. I just wanted to say that we really appreciate Vice President Crowley's comments about the work requirement for kind of pharmacy learners, and and would really welcome a discussion at a future meeting on what could be done to improve the way that pharmacy learners are able to prepare for coming into the profession. I'll say that we at Kaiser Permanente have many dozens of residency positions, and just anecdotally over the past few years we have noted increasing struggles with the board's licensing exams and kind of integrating into practice. And so, we would just really welcome a discussion on if there's anything that the board thinks is possible to just help our pharmacy learners be prepared to kind of hit the ground running once they graduate from pharmacy school. So thanks for bringing that up, Vice President Crowley. We appreciate it.
Thank you for the comments, Dr. Gray.
And at this point, I do not see any further requests for comment. Shall I close that public comment feature?
Yes, please, Moderator Ann. All right, everyone, we finished all our items of closed session yesterday. So thank you, everyone, for your participation. Always getting engaged, and everything you do. Really appreciate it. And also to the public. I know that we've met so many times, so it feels like we're gonna meet every month, but no, we won't. We won't be meeting until June. So I hope everybody has a wonderful. Yes.
Just to add to your thank yous, I'd like to thank our law enforcement officer who is sitting with us this entire time. Probably not the most exciting assignment to ever have, but really do appreciate you being here. Thank you.
Oh, thank you. Thanks to our CHP officer. Thank you. Just don't pull me over ever, please. Thank you. But I appreciate everyone. Thank you all for all you do. And we will see you all in June. And we'll keep you all apprised of what happens with our Sunset Progress as we move forward. And so keep an eye out on your emails. I hope you all had a great time in Sacramento. I'm sorry I wasn't there. But with that, the meeting is adjourned. Thank you, everybody. Take care.
Thank you. Bye, everyone.
Bye, Nicole.